የተወሰነ የግል ማህበር ነው። ዛሬ እዚህ የተገኘንበት ምክንያት እናንተ ላዘጋጃችሁት የሄልዝ ኤንድ ሜንታል ኮንፈረንስ ላይ ስፖንሰር በማድረግ ነው የመጣ ነው። እኛ ጊላንዶ ከሚንድሪ ሸንዘን ሚንድሪ ካምፓኒ ጋር አንድ ላይ ነው እዚህኛውን ፕሮዳክቶችን ፊት ለፊት ላይ ያቀርብንላችሁ። ጊላንዶ የተመሰረተው ኦልሞስት በዚህ 10ኛ ዓመቱን ይዟል። 10ኛ ዓመቱን ሲመሰረትም በአፍተር ሴልስ ሰርቪስ ላይ ደግሞ ሜዲካል ኢኩዊፕመንቶች ዳውን ታይማቸው ወደታች እንዳይወርድ ወይ ደግሞ የሚያጋጥማቸውን ፌለሪቲ ሶልቭ ለማድረግ ነው ወደዚህ ሶሉሽን ለመፍጠር ከዛሬ 10 ዓመት በፊት ስራ የጀመረው። ስለዚህ ጊላንዶ ከ10 ዓመት በኋላ ኢምፖርተር በመሆን እንጂ የምታዩቸውን የሜዲካል ኢኩዊፕመንቶችን በማምጣት በተለይ በኦሮሚያ ክልል ላይ በጣም በስፋት እያስፋፋን ያለው ማለት ነው። ስለዚህ ከዚህ ፕሮዳክት ለመጀመሪያ ያህል እዚህ ጋር የምታዩት የሜካኒካል ቬንቲሌተር ወይ ደግሞ ኢንቴንሲቭ ኬር ዩኒት ውስጥ የሚሰራ ሜካኒካል ቬንቲሌተር ማሽን ያለው ለአዳልትም ለፔዲያትሪሽንም የሚሆን ነው። ከዚህ ቀጥሎ የምታዩት ደግሞ ክሊያ ወይ ደግሞ ሆርሞን አናላይዘር በኦሮሚያ ክልሎች ውስጥ ኦልሞስት ወደ 10 ሄልዝ ፋሲሊቲዎች ውስጥ ገብቶ አሁን ስራ የጀመረ ማሽን ነው ማለት ነው። ከዚያ ውጪም ያለው የብለድ ካልቸር እና የማይክሮባዮሎጂ አጠቃላይ የአይዲሲቲ ወይ ደግሞ ድረግ ሰሰተቢሊቲ ማሽን የምንለውን ለእናንተ ይዞ መጥቷል። ይሄኛውም በተለያዩ ሆስፒታሎች ውስጥ አለ። በተለይ አዳማ ሪጂናል ላብ ይሄን በስፋት የተጠቀመበት ያለ ነው። ከዛ ውጪም ደግሞ ያለ እዚህ ጋር የምትመለከቱት M680 ብዙ ሶሉሽኖችን ይዞ የመጣ ወይ ደግሞ ኢንተግሬትድ ሲስተም የሚባል የተለያዩ ቴስቶችን በአንድ ላይ ኮምባይን አድርጎ በመስራት ያለ ማሽን ነው። ይሄ ማሽን የሚሰራው ትልቅ ካፓሲቲ ያለው ነው። ክሊኒካል ኬሚስትሪ ቴስቶችን ኤሌክትሮላይት እና ኢሚኖ አሴይ አንድ ላይ በማድረግ ወደ በሰዓት በጣም ትልቅ ስሩፑት ያለውን ቴስት እየሰራ ያለ ማሽን ነውና ይሄም ወደ 4 ሄልዝ ፋሲሊቲዎች ውስጥ እንደነ ቢሾፍቱ መቱ እና ሻሸመኔ ሆስፒታል ላይ ገብቶ ስራ እየጀመረ ያለ ነው። ይሄ በትልቅ ማሽን ነው። ወደ 3 በአንድ ሳምፕል 3 ቴስቶችን መስራት የሚችል ወይ ደግሞ ክሊኒካል ኬሚስትሪ በጣም ብዙ ቴስት ሞዳሊቲ ያለውንም ኢሚኖ አሴይንም ፕላስ ኤሌክትሮላይት ቴስቶችን በአንድ ሳምፕል በአንዴ ቲኤቲ ቫልዩም በጣም ረጅም ሰዓት ይወስድብን የነበረውን በአጭር ሰዓት ውስጥ ዊዝን በሾርት ታይም ኦፍ አወር የሚያወጣልን ማሽን ነውና እንደዚህ የመሳሰሉ ማሽኖችን ይዞላችሁ መጥቷል። ስለዚህ ጊላንዶ ከእናንተ ጋር በስፋት መስራት የሚፈልግ ድርጅት ነው። ሲመሰረትም የጤና ተቋማትን ችግር ለመፍታት እናንተ ጋር ያለውንም ችግር ለመፍታት የተቋቋመ ድርጅት ስለሆነ እንኳን ሰላም መጣችሁ። ላላችሁ ችግር ከሆነ አፍተር ሴል ሰርቪስም ከሆነ ኮንታክት ልታረጉን ትችላላችሁ። ከ40 በላይ በአሜሪካ ሰራተኞች አሉን። ከአይቪዲም በፔሜሊስም በኢሜጂንግም ለሁሉም ፕሮዳክቶች መፍትሄ ለማምጣት ነው እዚህ ኢትዮጵያ ላይ ድርጅት ከፍተን እየሰራን ያለው ነውና ስለዚህ አብረን እንስራ ለማለት ያልነው። እናመሰግናለን።
ጊላንዶ ጉዳ ገለቴፈና ሲሞ ፖስተሪ ላላደና
Welcome. My name is Mekonnen from Addis Ababa University, and I'm a PhD student. And one of my first work was resource mapping, that available resources that can be leveraged to the recovery-oriented care of people with severe psychosis. So we know the treatment gap for mental illness is very large. Even those who come to the healthcare, the refractory cases specifically for schizophrenia is 30%. So where are these people? Where are the resources that can be leveraged to recovery-oriented care of these people? We try to search and see at least selected area of Addis Ababa within 2 subcities, Kirkos and Lideta subcity. So we found many type of social and institutional organizations. The first one is we found 124 health facilities, 16 health centers, and 9 hospitals within these 2 subcities. And traditional healers 38 religious organization, 104 non-governmental organization or charitable organizations. So this all, and also from the social organization we found, which we didn't work still now in Ethiopia, specifically in Addis Ababa, is Iddir, Iqub, the important social organization that currently people are getting help, at least the social help they are seeking from this organization. So we tried to map the distribution of these resources, but because of the reform of Addis Ababa subsidy, we can't find the shape file of Addis Ababa subsidy to locate, but roughly we put this to see some distribution of the resources. So we are saying that there are many resources that can be leveraged to the recovery-oriented care of people with severe mental disorders. So I think this can be the first work of my PhD, and I will continue the development of model development of integration of mental health with physical health with social organization, including traditional and faith healers in my PhD. Thank you.
Namoonni gaaffii qabaatan yoo jiraatan boodarra gaafachuu dandeessu yeroo boqonnaa shayii yeroon keenya waan hin geenyeef.
Okay, my name is Mr. I am a PhD fellow in Jimma University. So this is one of my objectives. It is systematic review and meta-analysis. The title is Effectiveness of Text Messaging for Reducing Substance Use. As a background, we know that substance use is a major public health problem, especially for users, and it's highly related with risky sexual behavior, mental health issues, risky violent, and other related issues. Even though the problem is higher in users, we usually use traditional kind of treatment, a one-to-one kind of way of solving problems. So that's not effective because it has a limitation in reaching and acceptability by users. So we also have see that SMS or text messaging is effective in risky behavior and improving preventive health care, promoting chronic illness self-management. So we start having at that time questioning ourselves as to review whether this text messaging is effective for users or not. So based on this question, we try to address, to answer this question by using these methods. We search in detail with these databases. So we found finally as effective for text messaging for users. And also we subgroup those who follow for 3 months and those who follow for more than 3 months. Those who follow for 3 months is more important than that of more than 3 months, because if the message is more intensive and timing and more frequent, it's more important than that of following the patients more than 3 months. Within that, we finally conclude that this text messaging is effective for users. If you have any question, you are welcome.
Thank you, Mr. A, for your nice presentation. Then we continue to hear. So Brano will present his finding.
Okay, thank you. I'm Brahanu. I'm currently a PhD student at Addis Ababa University under the Department of Psychiatry. And my research area is abortion and mental health disorders. So we know that abortion is a procedure that is introduced recently as a procedure of maternal care. So it's not abortion that's causing depression or anxiety or mental disorder, but it is the factors that is related with psychosocial effects that could have a disorder. Therefore, this is the baseline data for the META project, and we have found that almost around 18.2% of women suffer from certain mental stresses. Therefore, there are certain factors that is highly related or acting as a risk factor, and from these factors, cohabitation, being unemployed, having less support, and stigma and discrimination, use of substance are highly related with that of common mental disorders after abortion. So the next project is to scale up this project to a comparative stage or comparative study, and this comparative study will include those who undergone abortion and those who did not receive abortion. And what is the experience or the life experience of these women? How do they experience mental disorders? Could be another objective. And the third one is, what does mental disorder mean for healthcare providers that are providing services, especially abortion services? And this is the project area. Therefore, this is simply, it is a baseline data. It's a first in Ethiopia to be done in abortion related disorders. So what we are going to recommend is we have to integrate the services, especially mental health services, in any other clinical areas, especially in maternal and child areas, because they suffer a lot. They suffer from the psychosocial point of view, so that they should have to have certain counselings that could address. I have seen the ministry guidelines that is serving as abortion guideline, and I found only one term that is speaking about mental health. It says mental and physical disorder. A single one, a single term. Therefore, we have to address this problem. It's a neglected area. Abortion by itself is neglecting, and mental disorder is another, so that we have to address this at a large scale. Thank you very much.
Thank you.
Hello. So I'm Addis Salam. Came from Debra Bran University. I have a topic on the research title: Persistent Mental Health Challenge, Prediction and Understanding Risk Factors Among Adult Population in Ethiopia. As you know, adult population face common mental health problem across the world. Globally, nearly 300 million people suffer from mental health problem, of which nearly more than 80% of the mental health problem occur in a low resource setting. For instance, in Ethiopia, 5% of the people struggle with mental health problem. Individuals with untreated mental health challenge will increase the odds of illness, the chance to develop more illness. They become an isolated person. They also become as societal addiction, and they are vulnerable for death. Therefore, this study aims to leverage machine learning algorithms specifically to predict the existing persistent mental health challenge, the frequency, how much the adult population faces for mental health problem, and to use the algorithms to identify and understand the risk factor for this persistent challenge, specifically for adult populations. Therefore, The data source for this study is found from World Health Organization and Communicable Disease Resource. As you know, we do have rich and very important secondary data, which is not yet well analyzed, but they are very important for policymakers and for healthcare practitioners. Therefore, I have accessed the data from NECD, non-communicable disease data repository site. I hope which is collected by Ethiopian Public Health Institute. And the total 9,923 samples are used. Then for this data, 9 algorithms are considered to develop, validate each algorithms to understand their prediction abilities or capabilities, performance using this data. Then before doing this, we set the data into, we have partitioned the data into training, testing data. For testing data, we use 80% from this total sample and 20 from this total sample for testing the performance of each algorithm. Then for, many algorithms are not, maybe unless we perform hyperparameter tuning for increasing their performance, specifically to reduce the false positive and false negative rate. Therefore, tenfold cross-validation was used to enhance model performance. Different performance evaluation matrices like true positive, false positive, including ROC curve used to evaluate
jiru haa ta'u malee yeroo keenyatti fayyadamuuf hin jalqabna. Again, welcome.
Persistent mental health challenge. There is a gap, there is a difference.
Okay, welcome back again. Ega tea break in booda participantonni keenya xinnoo ishee duubatti harkifachaa jiru. Haa ta'u malee yeroo keenyatti fayyadamuuf hin jalqabna. Again, welcome dear respected and distinguished guests, honors and participants as well as research presenters.
I have considered the adult value of 79.8 score, then it is the best model to predict persistent mental health challenge and to understand the risk factors. Okay, therefore, based on our prediction model, the prediction model shows that from this algorithm, almost 80% of the adult population are predicted to or classified to have a persistent mental health challenge. So what? Policymakers, before this problem is happen, they work on the adult population because the algorithm indicates that majority, nearly 80 of this are going to develop persistent mental health challenge unless proactive action is taken. Then again, the risk factor as age, the first one is based on our future important score. Age, marital status, work status, family size, time spent at school is or education. The top 5 important predictor for the persistent mental health challenges among adult population in Ethiopia. Therefore, what I recommend for the majority of the adult population, as we see, is developing or facing persistent mental health challenge. Different predictors are identified, stratified, then tailored and context specific for mental health intervention is very important. Very important. So thank you. It is my short.
Thank you, Salem, for your nice presentations. I think it's very nice, important, and it's very interesting. So, hundi keessan baay'ee galatooma. I think sagantaa keenya kanumaan xumurree gara panel discussion itti fufaa suuta jettanii kaameraa waan jiruuf miila keessan jala eeggachaa akkan kufne gara galmaatti seennachuudha. Ulfaadhaa. Yeroo boqonnaa shayii gaaffii siniin galle gaafachuu dandeessu. Minaalbaata warri mindirees garana jiru. Warri poster presentationis yeroo boqonnaa shayii as jiru waan ta'eef kan gaaffii sinitti ta'u gaafachuu dandeessu. Thank you. assistant professors working in Madhya University. So the second panel discussions will be continued. So he will take the podium and invite the panelists. So I directly go to Dr. Adam Ismail. Thank you. Stay with us.
Good morning. It's really more than honor and a privilege to see, to hear such large event nationally, speaking on the mental health service in Ethiopia. So as a person practicing in mental health professional, as well as just representing mental health professionals of Ethiopia, I'm really happy and I would like to appreciate agents behind this event, Ethiopia Health Bureau, Ali Birra Foundations and others. So thank you very much. Saying this, I would like to welcome my panelists. I would like to welcome my panelists. The first panelist is Professor Talaka Azzala. He is currently a professor of mental health, epidemiology, and public health at the University of Gondar. He has about more than 20 years teaching, as well as research and community service, leadership experiences, as well as a reviewer and editor of national and international journals, and he has authored and co-authored more than 200 research articles. I would like to welcome again Dr. Birra Taha. Is a 6-year resident of at the University of Minnesota, USA, with a strong clinical and academic foundations of neuroscience. He has cultivated extensive research experience and computational neuroscience and neuroimaging, neurooncology, as well as is contributing on the innovative approach of brain tumor and diagnostic and surgical approach. So driven by both technical excellence and compassionate care, Dr. Taha represents a new generation of neurosurgeons and surgeons and dedicated to pushing boundaries of pediatric brain health. So mainly his topic is on mental health from inside to out, in respective to neurology. I will come again. Dr. Lulu Bakana is a distinguished psychiatrist at Emmanuel Mental Specialized Hospital with more than 14 years of clinical research leadership experiences, and at the level of different from starting as a department head, research and training director, as well as clinical director of Emmanuel Mental Specialized Hospital, and is also national mental health trainer. Next, I will come Sister Agitu, mental health specialist from Ministry of Health Mental Health Desk. Sister Agitu have experience of more than 20 years, clinical, academic, as well as research activities at Emmanuel Mental Health Specialized Hospital, and currently working at Ministry of Health as a senior expert of national mental health program, and also actively involving on shaping national mental health strategy, clinical policy, as well as coordinating different development of national guideline and training manuals. So she also working on the promotion and advocacy of mental health, as well as integration of mental health in our nation. Next, I will come Mr. Zagaye Yohannes. He's an experienced senior mental health specialist with experience more than 15 years in clinical, academic, as well as leadership. Currently, he is a president of Ethiopian Mental Health Professionals Association, and also he is a board member of Ethiopian Professional Association Alliance, research and training director currently at Emmanuel Mental Specialized Hospital, and he contributed more than 15 publications at national and international reputable journals. Saying this, so now we'll start our panel discussion, and to directly proceed to our today's or to this session panel discussion, which is a continuation of our yesterday panel discussion. The subtheme for this panel discussion is considering mental health, health training, research and policies in perspective of Ethiopia, learning from the past and framing for the future. So I will have some specific questions for this particular subtheme inputs from my panelists. So the first point will be addressed by Sister Agitu, which is mainly related to the progress and the current state of mental health training in Ethiopia. So I will give a chance to Sister Agitu to address on this area for 5 minutes, please.
Thank you. I would like to say Happy World Mental Health Day for all of you. Today is the day on which we are celebrating mental health day worldwide. My colleagues are celebrating this day in other places. I am honored to be here to have this event, which is prepared by Oromiyaa Health Bureau and also Ali Birra Foundation. Really, I am grateful to be here and to participate in this event. Again, I will say to all of you, Happy World Mental Health Day. Baga ittiin isin ga'e guyyaa nageenya sammuu itti kabajnudha. Waa'een nageenya sammuu dhimma nama dhuunfaa, dhimma maatii, dhimma uummata hundumaati. Guyyaan kun egaa guyyaa addaati. Maaliifi guyyaatti waa'ee nageenya sammuu akka biyyoolessaatti, akka biyya lafaa hundumaatti itti yaadatamudha. Kan yeroon jedhu baay'ee natti tola. Thank you. I will go to my points, which I am just to present. What is the progress and current state of mental health training? This topic goes beyond 14 years in Ethiopia, where it is started in at Emmanuel Hospital for more than 40 years back in diploma psychiatry. As we know, formerly Emmanuel Hospital is addressing the mental health issues in the country regarding training, supervision and everything. At that time, diploma psychiatry nursing or advanced diploma is started as an Ethiopian calendar in 1979. Which goes for around 20 years and also produced around 450 psychiatry nurses which were working on the regions and other health facilities. Again, when we come back to another progress, around 2001 in Ethiopian calendar, Gondar University and Mekelle University started to give psychiatry nursing under BSc. So they started again master's program is started in integrated clinical and community mental health jointly with Emmanuel Hospital at Gondar University. This is the progress and is a good progress. Almost around 10 to 12 universities give BSc psychiatry in our country. The other is when we come to the residency in Ethiopia, residency started around 1994 in Ethiopian calendar. Before that, the specialty, the residency is given abroad. Currently, Ethiopia do have almost 5 universities giving residency for medical areas. So We do have around 165 to 180 psychiatrists in our country. In this case, we do have only specialists working in child, only 4 for our country, 1 addiction psychiatrist, only 1 forensic psychiatrist, but we do not have other specialties in psychiatry area. This is the training which is given. We are seeing a lot of progress on the training setup. When we come to the Ministry of Health, we do have trainings under mental health program, which is given for health professionals. The one is integration of mental health into primary health care unit to access the services into the health centers and other health facilities. This is the WHO training manual which we are using, the MHGAP IG or the Mental Health Gap Action Program to integrate mental health service into primary health care units, which is developed for developing countries. We are giving training for all regions, with coordinating with regional health bureaus. The other is refresher training courses we do have. Currently, we do have around 5 materials prepared in the Ministry of Health, especially for mental health professionals. The one is the neurological aspect regarding substance use treatment for psychological intervention and mental health. Oromiyaa Xeenaa Bureau or Oromiyaa Health Bureau is just launched and just is working on this. He give this refresher training for around 90 health professionals working in Oromiyaa setup. I would like to thank Oromiyaa Health Bureau. They are the pioneer to use this material. The other is we integrate, currently we are working on the integration of mental health into diseases. Currently we are working with integration of mental health with HIV care. The other is we are providing other training for integration of mental health and the psychosocial support with cancer care. Again, we are just working on integration of mental health with TB treatment. Some of the trainings which I do have to update are these. Thank you.
Okay, thank you, Sister Agitu, for addressing very important points, especially the training on mental health area from the past, which is a lack of a drop, started as from diploma level, and later specialists are also started. Nowadays, we have BSc in addition, master's program in addition, as well. For the last 10 years, there wasn't been in-service training for mental health professionals, whether BSc, masters, or specialties. But with the work of Minister of Health Mental Health Desk, refresher training or in-service training manuals were prepared. Oromiyaa Regional Health Bureau is the first to inaugurate and start refresher training after graduates are like practicing without training for the last 10 years, but Oromiyaa Bureau started last year, thanks to Oromiyaa Regional Health Bureau and CD Desk especially. So saying this, I will proceed to the next point of discussion, which is mental health research in Ethiopia, past, present, and the future. This point will be addressed by Professor Talaka. Please, Professor Talaka.
Good morning, everybody. Thank you very much. I would like to appreciate Oromiyaa Health Bureau for initiating this wonderful international conference. Probably Oromiyaa Health Bureau is the only regional health bureau who ever has prepared such an event. Thank you very much for that. Saying this, I would like to briefly talk about the research developments in mental health in Ethiopia. Training, research, and policy are inseparable. One influences the other. Of course, training provides with the knowledge and a skill of conducting research, generating evidence to influence policy, enhance mental health service, provide quality and equity mental health service. So the advancement of research in mental health has been burgeoning with the expansion of mental health training. The earliest research in mental health were limited to institutions and were only prevalence studies and were mainly conducted by foreign experts, scholars. And it's since the mid-1980s, after the commencement of training of psychiatrists, and in the early 20s, after the commencement of the training of master's level mental health professionals, that most of the researches are being conducted now, because the training of master's level mental health professional requires them to conduct research on mental health topics. And we can classify the research in Ethiopia as first level, second and third level, depending on the rigor, the coverage of the research. The earliest researches were mainly cross-sectional and in institutions, and later on some more rigorous researches such as longitudinal cohort studies and now experimental studies are being conducted in Ethiopia. There is no nationally representative research about the prevalence of most of the psychiatric disorders. However, today there are more than 700,000 publications in Ethiopia on mental health topics. And therefore, now researchers are producing rigorous research outcomes to influence mental health policy and improve mental health quality and equity. And therefore, research is now burgeoning, and there are hundreds of publications per month on mental health topics, and most of them are on very few mental health topics. Probably more than half of them are on depression and comorbidities with depression, such as depression in patients with medical conditions such as HIV, chronic non-communicable diseases. But research is limited, especially on adolescent mental health, child mental health, and substance-related disorders. Most of the research on substance-related disorders are simply frequencies, proportions, and there are no rigorous research undertakings on most of the mental health problems, because we have more than 300 psychiatric disorders with their specifiers. Probably they may be more than 600, and research is limited only on very few, especially mental health disorders that are known priority mental health disorders according to the World Health Organization, such as depressive disorders, which has about 16 variants with their specifiers, including peripartum depression, antenatal and postnatal depression, anxiety disorders, psychotic disorders, mainly schizophrenia, spectrum disorders, and substance disorders, mainly alcohol use disorders, not actually the use disorders, but usually research is on the frequency or the prevalence of alcohol use. There are no many research on the use disorders, and the screening tools that are used for mental health research usually were developed in the Western countries, and most of them require validation, cultural adaptation. However, we use most of them as they are, and I don't think they actually measure what is happening on the ground. And today there is a need to validate those tools, and we are pressurizing PhD students, because we have trainings on PhD in mental health epidemiology in Addis Ababa University and University of Gondar, and we require our PhD students to validate screening tools, because there are about 1,800 screening tools to measure mental health disorders. If you pick only screening tools for depression, there are more than 15 screening tools, and we don't know which tool is the most appropriate for measuring psychiatric disorders in our setting. So we need to validate screening tools, and we push our PhD students to validate these tools before they use to measure psychiatric problems. So this is what I can say about the development of research in mental health. Thank you very much.
Thank you, Professor, for your points on research in Ethiopia related to mental health, past, present, and future context. I hope researchers and the professionals get a critical point on here, especially on the limitation raised. Again, I'll go to next point, which is again addressed by Professor Talaka. What mental health epidemiology in Ethiopia looks like, and regarding the risk factors and the consequences or related to recoveries. Thank you.
Thank you very much once again. So concerning the epidemiology of mental health disorders, when we talk about epidemiology of mental health disorders, we are referring to the occurrence, frequency, distribution, and determinants of more than 300 psychiatric disorders. And this epidemiology varies according to different characteristics of people. Each psychiatric disorder and its epidemiology varies according to age. Some psychiatric disorders are more prevalent in a certain age group. For example, if you take schizophrenia, it mainly affects the productive population, the young population, 15 to 24 years of age, and about 50% of schizophrenia have their onset below 20 years of age. And there are some psychiatric disorders that are more common in children. Other psychiatric disorders are more common in the elderly, for example, neurocognitive disorders, neurodevelopmental disorders such as the autism spectrum disorder, intellectual disabilities, attention deficit hyperactivity disorders, and other disruptive and behavioral disorders occur in children. And there are also variations in sex. Most of the psychiatric disorders affect females more than males, unfortunately, probably because females carry more responsibilities in caring for family, and they may be exposed to several risk factors that are related to pregnancy and childbirth, hormonal fluctuations, and several burdens such as domestic violence and intimate partner violence. As a result, most of the psychiatric disorders are more prevalent in females than in males. If you take, for example, depression is twice more common in females than males. There are also some psychiatric disorders that occur only in females. For example, premenstrual dysphoric disorder, and postpartum depression, antenatal depression, they can't occur in males, definitely. And some disorders affect men and women equally. For example, schizophrenia. The prevalence of schizophrenia is estimated to be about 1%, and it affects men and female equally. And the disorders with the highest prevalence are depressive disorders and anxiety disorders, estimated to be affecting about 15 to 20% of the population. And globally, it is estimated that 1 in 7 people are affected by a mental health condition, and a total of 1.1 billion people is estimated to live with a certain mental disorder today. And there are disorders known as priority mental disorders by the World Health Organization. These are priority because of their high prevalence, because of their capacity to lead to disability, and because they are severe. Some of them require long-term treatment. And these priority mental health disorders include depressive disorders that affect about 20% of women and about 12% of men. Psychotic disorders, or mainly schizophrenia spectrum disorder, about 1%, and usually occurs among young people, and more in urban than in rural settings. I mean, they are more common in urban than in rural settings, and they are more common among the poor people, uneducated people, and those who are exposed to stressful situations and childhood adverse experiences. And the other priority mental disorders are bipolar disorders. Bipolar disorder also affects about 1.5% of the total population, and these are slightly higher among men, and they usually occur in mid-20s to 40s. Others are anxiety disorders. They are also very common disorders, probably next to depressive disorders. Of course, depressive disorders and anxiety disorders are very highly correlating, occurring about in 90% of patients with or persons with anxiety disorders also may have depressive disorder. The other priority disorders are neurocognitive disorders, especially dementia, and childhood disorders, mainly autism spectrum disorders, and intellectual disabilities, attention deficit hyperactivity disorder, and substance-related disorders. Epilepsy is also, although not a psychiatric disorder, included under the priority disorders for which the WHO is recommending to be integrated with primary health care, and these disorders are very, very common. However, we don't have a nationally representative data on the prevalence of each of the psychiatric disorders. I think this is what I can say about the epidemiology. Thank you very much.
Yeah, thank you, Professor Talaka, for addressing the condition of mental health epidemiology in Ethiopia, respective to risk factors and consequences. The next area of
the risk factors and consequences, shall I say?
Yeah, 2 minutes.
Sorry, I skipped the risk factors and the consequence of mental health disorders. So generally, the risk factors of mental health disorders are said to be the biopsychosocial and spiritual model, as well as environmental factors. So there are biological factors, including family history of mental illness, genetic abnormalities, biological factors, including neurotransmitters, hormonal imbalances, deficiencies, or excesses, and psychosocial factors such as losses, any stressful events and situations. This can be natural disasters or man-made catastrophes. When it comes to Ethiopia, mainly the man-made disasters are more prevalent than the natural disasters. Fortunately, we don't have the natural disasters that are very rampant in the developed world, such as earthquake, floods, and tornadoes, and wildfires are not very common in Ethiopia, but the human-made catastrophes are very common. Conflict, war, armed conflict are very common, and these are among the psychosocial and environmental factors that contribute to mental health problems. The consequences of mental health disorders are very, very rampant. Many of the psychiatric disorders may lead to suicide. This is one of the consequences of untreated psychiatric disorders. If we take depression, about 15 to 25% of persons with depression may commit suicide, and about 10% of people with schizophrenia and substance-related disorders may commit suicide. This is one very major consequence of untreated psychiatric disorders. The other consequence of psychiatric disorders is exposure to other medical conditions, exposure to substance use disorder on top of a mental health disorder. And many psychiatric disorders lead to disability, for example, schizophrenia, disability as a result of the disorder itself, and disability may also result from the side effect of antipsychotic medications, unfortunately, and it may be a permanent disability. This loss of productivity, not just limited to the individual, but also to the family caring to the patient, also to the healthcare system, and to the government as well. There is a loss of productivity, and disability life years are very common as a result of psychiatric disorders. And persons with psychiatric disorders are likely to die 10 to 12 years earlier than the general population. That means life expectancy of persons with psychiatric disorders is shorter than life expectancy of the normal people. So it reduces life expectancy, and many distractions. Some persons may be dangerous actually, not all persons, but some may also commit homicide in addition to suicide. And these are some of the consequences of untreated psychiatric disorders. Thank you.
Okay, thank you, Professor, for addressing very critical issues. Now, the point of our discussion is how we explain the current mental health policy perspectives, and it is translational and practice at the national, at the regional, and as well as lower level of our practice. So this area will be addressed by Sister Agitu. So please, Sister Agitu.
Thank you. Currently, we do have a national mental health strategy, which is this year is the final year, because it is from 2022 to 2025. We do have priority areas on our national mental health strategic plan. Priority area 1 shows governance, leadership, coordination, collaboration, and partnership. And these areas, the progress is, this is endorsed by Ministry of Health. It is integrated into the HSTP 2 or Health Strategic Transformation Plan 2, recognized in National Emergency Response Framework. Partnership have been established with non-governmental organizations and other governmental organizations. When we see in this area, the gaps are weak institutional coordination between other sectors like education, social protection, other organizations, because coordination, collaboration is needed in every sector to achieve the goal. This is the gap. The other is absence of dedicated budget regarding mental health within regional health bureaus, zonal and waradas to address. This is the gap. Also inadequate or integration to access the service. These are the gaps which we do have on the governance, leadership, coordination, and collaboration areas. On the priority area 2, development of adequate and competent human resource. This is ongoing. We do have human resources and some of the aspects, but we didn't cover all the health facilities in our country with mental health professionals and trained manpower. But the progress is good. We do have around 480 BSc psychiatrists, nurses working in local areas. Image gap training given for around 1,600 non-mental health professionals for task shifting to assess, screen, manage, and refer mental health conditions. Growing involvement of health extension workers is there to identify the community level mental health problems at home level, but it is still inadequate to reach out others. On the promotion and the prevention of mental health issues, we are working on the advocacy of mental health areas, national awareness campaigns, Like this month, October month, we are working on advocacy through mass media, through gatherings and panel discussions. This can help to reduce stigma and to promote mental health. This is the other aspect. Also, we are working to integrate into the community on the promotion activities with religious leaders and community leaders. Still, stigma is there in the community. So this is our priority area in which we are working. Also, it needs scale up and working on the advocacy and also on the awareness creation campaigns in schools, in communities, and in other gatherings. It needs focus to do on that. The other is priority area 4, integrating clinical service. This also needs more to do on that, but we are working on this. In Ethiopia, we do have around 353 hospitals, 3,700 health centers, and also 17,000 health posts. But the coverage of mental health service, when we see only 70% of our hospitals are giving mental health service in outpatient and in inpatient level using psychiatry professionals. And we do have only around 600 health centers giving mental health service through MHGAP trained psychiatry professionals and other psychiatry professionals. So the gap is there. So low treatment coverage is our gap. Sometimes there are interruption of antipsychotic medication in our health facilities. Limited service for children and adolescents regarding mental health is our major gap. People with disabilities and homeless patients, those who are homeless and have severe mental health problems are not addressed. So this is our gap regarding the service. The other priority area is our research and surveillance, monitoring and evaluation. In this aspect, we do not have a nationally representative data regarding mental health problems for each of the disorders. This is the gap, and we call for the researchers to do and to engage on the national mental health related researches. The other is monitoring and evaluation is ongoing, but it is not enough when we see there is still a gap in budgets and resources, and we need for more collaboration and working together. Thank you.
Okay, thank you, Agitu, for addressing really important issues regarding the translation of policy toward the practice. Actually, I hope I will be back to you, and I hope you will say something on the integration versus the unemployment of psychiatric professionals. Integration through MHGAP training is a WHO program, which was really effective for developing countries, and our countries also really implementing and get some benefit from it. And then when we see on the other side, psychiatric professionals, be psychiatrian, are being unemployed, we will come to later. I hope we have point to say on that later after we hear from the next panelist regarding the number as well as the role of professional association. So as we know, in Ethiopia, we do have professional associations working on mental health related, representing the professionals: Ethiopian Mental Health Professionals Association, Ethiopian Psychiatrist Association, Ethiopian Psychologist Association, plus Ethiopian Social Workers Association. These all are partners working, supporting, contributing by collaborating with the Ministry of Health and other regional health bureaus. So now I have a point to be addressed by Mr. Zagaye, which is the role of professional associations in bridging the research as well as the practices through the integration or through the bridging the gaps through research as well as practice. What is the role of health professionals? So this is time for Mr. Zagaye, please.
Thank you. I would like to thank Oromiyaa Health Bureau and Ali Birra Foundation for giving this chance to represent professional associations in mental health. Saying this, as Dr. Adam mentioned, we have around 5 different professional associations who are linked with mental health: Ethiopian Psychiatrist Association, Ethiopian Mental Health Association that I represent, and Ethiopian Psychologist Association, Ethiopian Social Work Associations. These are professional associations mainly focusing on mental health areas. However, there are so many difficulties, as you all know. I hope you are also in one or another way member of professional association. So you know the challenges and the limitations of professional associations. So Ethiopian Mental Health Association is a professional association, mainly includes mental health master's graduates and undergraduate psychiatric nurses. And we have recently around 1,200 members, and around 500 of them are active members. So professional associations have significant role in mental health services, research, as well as training. We are just to mention some of the gaps from my perspective. There are significant gaps in training and also research areas as well as service. So what are the gaps related with training? So the first one is both in-service training as well as pre-service training. We believe that there are gaps on the curriculum, gaps in the way they provide training, especially some of the cultural aspects and community-based service aspects may not be well included in the curriculum. So the associations are working including our association, working on the curriculum revisions, and we are actively working with universities. As mentioned before, psychiatric trainings are, the number of universities increased in the last 10 years from 2 to 3 universities to around 15 universities currently. So it's growing. However, we are still working on the curriculum issues related with gaps in the curriculum. So the other one is service. As mentioned previously, there are limited access to mental health service still, as we compare to the total health service coverage of Ethiopia, and the mental health service provided in these health facilities. Still, we should work more. Even though through time, the service coverage is increasing due to increased number of professionals, mental health professionals, as well as non-mental health specialists who are trained on MHGAP. And we are still also providing trainings, especially for non-mental health professionals, through our associations. So we are actively engaged in providing training through our members. We work actively with Ministry of Health as well as Oromiyaa Health Bureau. I would like to thank Oromiyaa Health Bureau NUCD desk for giving the chance. We try to train hundreds of professionals on MHGAP. And the other one is the gap is research-related gap. there are limited research activities, locally, especially producing locally relevant data. So the capacity of the research, when you see the mental health research, even though it's growing, still we believe that more should be done. And as previously mentioned, we don't have nationally representative data. We don't have the mental health research is not included in the national surveys. So we are pushing to include at least the most common prioritized mental health problems in the national surveys. And the other one is there is also low priority of funding and also budget allocated for mental health research. So we are also advocating to fund, to consider mental health during funding for research. So professional associations have, when you see the whole number of professionals in our country, as previously mentioned, we have around 180 psychiatrists, and we have around 516 mental health specialists who are master's level graduates. They are taking the lion's share in the providing services in the country because they are working almost in all regions, and also they provide training in the universities for students, for undergraduate students. And also we have recently around 2,377 psychiatric nurses who are trained in the last almost 15 years. So the training was started by Emmanuel Hospital. As you all know, Emmanuel Mental Specialized Hospital is the biggest and the only specialized center and the referral center for the country. And we started, I'm also working at Emmanuel Hospital, so we started the master's program as well as the undergraduate program in collaboration with University of Gondar and Mekelle University. And later on, also Jimma University started MSc program by itself. So this MSc program mainly started due to shortage of specialists in our country. As you all know, we have few specialists, even though the number of specialists also growing growing through time, even though most of them are still working in urban cities, including Addis. So the mental health coverage in regional and in woredas and zonal areas are mainly covered by MSc and BSc psychiatry professionals. So we, as a mental health professional association, we encourage to coordinate research, training, as well as service provision to high quality for patient who needs mental health services. So the professional association have significant role in bridging the gaps, and we are recently working closely with Ministry of Health, Ministry of Education, and also Oromiyaa Health Bureau and other health bureaus in the country. Thank you.
Thank you, Mr. Zagaye, for addressing the issue of especially the role of professional associations and mental health services in bridging the gaps. And now the time is to discuss on the role of innovation in mental health service, because we are in the era of digitalization and innovation. So what's the role of innovation to the mental health regarding the diagnosis, care, and the services? So this area will be addressed by two of my panelists, Dr. Lulu and again Dr. Birra Taha. So I will give a chance to Dr. Lulu first.
Thank you. I would like to thank Oromiyaa Xeenaa Bureau and Ali Birra Foundation for giving me this chance. As you know, I'm working in Emmanuel Mental Hospital, and Emmanuel Hospital is the largest hospital. We provide in a year, we treat about 138,000 patients, and these patients are patients with severe mental illness. Innovations for us is to improve quality and to increase access. Concerning quality, we are trying to integrate medical service along with mental health service, because as you know, most of mentally ill patients have medical illness. Research says that more than mentally ill patients are 7 times more susceptible to develop medical illness. So ignoring medical illness in mentally ill patient is not right. It is not the way of giving quality service. So especially in the last 2-3 years, we are integrating medical service to our service. And every patient who came to Emmanuel Hospital, currently I'm working at the emergency department, I'm head of emergency department. Every patient who presents with medical illness, we evaluate him for physical illness. We have GPs, internists, and he will be evaluated for any medical illness, okay? Even though he didn't talk about medical illness, we know that mentally ill patients, most of them have a problem to say they have this type of illness or this type of symptoms. So we do physical examination, laboratory examinations for every patient that presents to our hospital. And I think this is the best way of approaching mental ill patients. Mental ill patients are more susceptible to develop diabetes mellitus. They are more susceptible to develop cardiovascular disease. They are more susceptible to develop hypertension. They are more susceptible to develop infections because their immunity is not as strong as in healthy individuals. So they are very susceptible to develop physical illness. So every patient should get medical assessment. So this is one way of assuring quality service to our patient. We do every laboratory examinations. We do, if imaging is necessary, either we transfer or we will give them the service at the hospital. So integrating mental health, medical service to mental hospital is one way of improving quality. So currently we are assuring quality by evaluating our patients or giving our patient medical service, medical evaluations. Also, we are trying to establish a surgical unit, especially for emergency patients. Still, mentally ill patients have a risk to develop surgical problems. Some of our patients might develop obstructions. Previously, what we were doing was referring to other general medical hospitals. But because of high stigma and discriminations, most of our patients not treated well at general hospitals. So to encounter this problem, what we are doing, especially in this year, to establish the surgical ward. So one innovative approach for mental health service provision is integrating every medical discipline in the hospital. Our patient can have tooth problem. Even they are more susceptible to develop tooth problem. So we have to integrate medical disciplines in mental hospitals. The other innovative approach should be to general hospital. My advice is every general hospital should have a mental health service unit. Or every department should able to screen for mental illness. Otherwise, they couldn't give a quality service, even to medical patients. A cardiac patient, almost all can have mental illness because of the direct effect of the cardiac problem, because of the physiologic effect of the cardiac problem, patient can develop a mental illness. While there is a mental problems in the patient, it will be very hard to control the heart problem. It will be very difficult to control the hypertension. A patient who have hypertension, if you ignore any mental illness in the patient, it will be very difficult to control the blood pressures. The same is in diabetes mellitus. It will be very difficult to control the sugar while the patient have stress and depression. So another approach is to give training to non-mental health professionals so that they can evaluate or they can screen mental ill patients. In HIV unit, in RDT unit, as you know, most HIV patients have mental illness. They have depression, they have stress because of not having, because of the things that they have the illness, because of the direct effect of the virus on the brain, because of the direct effect of the medication, because of the direct effect of the opportunity infections, the nutritional imbalance in HIV patients. So ignoring mental health in this patient, ignoring screening mental illness in this patient will not assure quality service. So the other is integrating mental health in general hospital. And I hope this is also, the Minister of also think in this way. So I hope other medical hospitals also will have a mental health service in their service. Okay. The other is maybe the technology. Maybe this will not as strong in Ethiopia. Maybe the experience might be shared from other speaker. But the other innovation, what we are trying to do in Emmanuel Hospital is, the other problem is most of patients who came to our hospital, who present our hospital, is they came after suffering for a lot of years. So we can't treat patient at early age. What we are planning in this year is also we are preparing a project. We wrote a concept paper just to work with the Ministry of Education and the schools so that we can get mentally ill or we can screen mentally ill children at school level. If you teach or if we train teachers working in that school, if you give them some screening tool, they might able to detect children with mental illness. With this, we can approach children in the school, and with this, we can treat mental illness at early phase. So the other innovative approach should be treating or giving treatment at early age. The other will be reducing premature days. To reduce premature days, as I have said already, integrating or considering mental illness is a part of medical illness is one way of minimizing or reducing premature days. A medical patient can have psychiatric illness. If the psychiatric illness couldn't be treated, it will complicate the medical illness. This will cause premature death. Also, a psychiatric patient might have physical illness. If you ignore treating the physical illness, this will also cause premature death. So working on this side also reduce premature deaths in mentally ill patient as well as also in medical patient. Also suicide is very important cause of premature death. So early treatment and aggressive treatment will reduce the premature death due to suicide. The other is availing necessary medications, new medication for a patient. Concerning Emmanuel Hospital, we have first generation and second generation. And we are almost, most of the time, we avail the drug, but sometimes some important drugs might not be available, like clozapine. Otherwise, most of the time, we are trying to give a quality service to our patient. The other is treating patients with machines like electroconvulsive therapy, and we are doing this. And this is all I have. Thank you.
Okay, thank you, Dr. Lulu, for raising really critical issue from point of practical experience at Emmanuel Mental Specialized Hospital, and also the point which can be taken as fix the software while you are fixing the hardware. I think we'll come back in summary later. The same issue will be addressed by Dr. Birra Taha, especially from the perspectives of neurology, from inside to out. Please, Dr. Birra.
Yeah, I want to first say thank you to Ali Birra Foundation for inviting me, and the Oromiyaa Health Bureau, of course, and all the participants and guests and fellow panelists. Small correction, but I'm actually neurosurgery trained, so my perspectives are more from a surgical aspect. I'm at the University of Minnesota in the neurosurgery program, and our intersections with mental health are really seeing the sickest of the sick, the medically refractory patients who really have reached the end of the line in terms of management. So in our clinics are some of the sickest patients, the most depressed, the ones that have failed multiple, for example, in major depression disorder, patients that have obviously failed medical management, have failed electroconvulsive therapy, multiple rounds, and have reached the end of the line. And they, it seems quite odd to ask a surgeon to come and fix a problem that is classically fixed with medication. So, when we encounter these people in clinic, often our psychiatry colleagues are there, and it's quite evident to us that this is a patient that has reached the limits of what medical management can do. So from the neurosurgery side, our perspectives go back many decades, and I'll be giving a bit of a discussion on this later in my talk, but the original role for neurosurgery in psychiatry goes back to basic lesioning. So neurosurgeons many, many decades ago in the United States and abroad would perform something called lobotomies, which were essentially causing severe damage to the frontal lobes. And this, at the time, would produce a very subdued phenotype, which was confused for success. So rather than having a patient who is medically refractory, who is having active suicidal ideation, who has all the negative symptoms and positive symptoms of schizophrenia, now without a frontal lobe and without an ability to coherently discuss or interact with the world, is now being told, you're cured of schizophrenia. So most at the time consider this a success, but obviously we have modern medicine and modern perspectives now to tell us that a subdued person without a frontal lobe is not a cured schizophrenic. So, I think this is an interesting perspective that, like I said, I'll talk about more in my talk. But modern neurosurgery, modern neurosurgery's intersections with psychiatry is mostly in neuromodulation. So deep brain stimulation, vagal nerve stimulation, cortical stimulation. These are techniques that neurosurgeons have for, again, the most medically refractory patients and the sickest patients in the hospital. For us, what we've, particularly at the University of Minnesota, we have a very robust neuromodulation program, particularly the deep brain stimulation program. Most of deep brain stimulation is reserved for movement disorders, so essential tremor, Parkinson's disease, dystonia, but a large part of deep brain stimulation is actually reserved for a lot of mental health disorders, such as treatment refractory, major depressive disorder, bipolar 1, 2, and bipolar 2, post-traumatic stress disorder, self-injurious behavior. These are all modern indications that 20 years ago, if you considered deep brain stimulation for post-traumatic stress disorder, you'd be laughed at. But these are now, even very recent publications on phase 1 trials are showing tremendous amount of toleration and success. So these are mostly mostly off-label use, and these are devices being granted humanitarian exemptions, but the success certainly cannot be ignored. Most of these treatments are actually done in an interdisciplinary way. So the neurosurgery department performs these procedures in coordination with our psychiatrists. So oftentimes in the operating room, our psychiatrists are there with us just to show how intimate our relationship is with the psychiatrist in treating a patient that often the psychiatrist has known for decades and has really been struggling to manage their disease process. So, much to what my colleague was saying in terms of interdisciplinary involvement with other specialties, it really, mental health is really a disease that extends to many departments, including neurosurgery and neurology. Oftentimes, in the discussion of who gets deep brain stimulation, who gets vagal nerve stimulation, this is really done as a group in case conferences. Having attended those myself, it's a very interesting discussion board. You will have psychiatrists very strongly advocating for their patients that obviously they've known for many years, and then a neurosurgeon will oftentimes be the one to decide, are there any actionable targets here? The research potential is obviously very huge in this area. The University of Minnesota in particular has a very robust imaging program, and they are working on techniques to better identify targets for deep brain stimulation. So, I don't want to get too much into the details of techniques like cortical stimulation and deep brain stimulation, but the basic motivation is implanting an electrode deep into the brain that can stimulate with high frequency an area that modulates greater pathways that obviously connect to frontal lobe and other areas that modulate reward, excitability, emotional ability, and some of these pathways that have direct implications on many of the mental health disorders that we talk about today. So obviously this is a program that is very costly currently, but it's really on the forefront of what's possible. And I think as an Ethiopian, I can't help but think it's only a matter of time until some of these technologies come here and we're able to discuss about some of these very new and growing indications. So, thank you.
Yeah, thank you, Dr. Birra Taha, for the points you have addressed on the innovation, the role of innovation in mental health treatment, especially regarding the neurosurgery and the new approach in the treatment of mental health care. So now, to the end, when I summarize our panel discussion, first, the issue of training of mental health professionals in Ethiopia, pre-service and pre-service and in-service. It was really started gradually through diploma graduates, which is about 20 years back. And nowadays, we do have much, probably to our context, when you compare with the previous, we can say much amount of psychiatrists, even though concentrated on the center. We have about 560 master's graduate, as well as about 2,337 BSc graduates. So even though when you compare with that of WHO standard to the professionals population ratio, it's incomparable. It's really very far away, but still to our context, if we able to use or able to get these professionals on the practice, I hope they can do their best. Regarding the research addressed by Professor Talaka, similarly it's related to that of training approach we have been following previously, like cross-sectional and other kinds of research, even not much attention given. But nowadays we have a kinds of longitudinal studies, even though we have some limitations of data nationally as well as on some areas, especially the child substance and others as raised by Professor Talaka. We also need operational research. For example, as starting from yesterday on this panel discussion, there were an issue being raised, which is paradoxical approach of integration. Integration is really good approach to decrease stigma and also to make the mental health service accessible at the community level. But when it pushes psychiatry professionals, make it unemployable, so that's another burden to the nation. So even though the integration approach need to be further addressed by the research, whether it's effective or not, the other issue which pushes the professionals would also need to be considered. And the epidemiology of mental health in Ethiopia nowadays is really really concerning issue, public concern, as everyone is noticing, being noticed in our area of work or living because of different factors as raised on this panel discussion from our panelist professor. So a lot of biopsychosocial risks are being nowadays much, especially the association of our context, natural and man-made crisis, are contributing mainly for the emerging of or even raising, escalating of mental health condition. Our context, substance, social media use issue, as well as parental, as well as the presence of different stressful conditions in our context. So to the policy and again translating, aligning or strategies as addressed by Sister Agitu, there is a priority areas like coordination, partnership, as well as coordinations. Even nowadays what is being done well is previously professional associations and government agents are most of the time like asking and getting response. But now it's time for collaboration since the COVID, it is more on this area. And the professional associations are collaborating with the governments, starting from Ministry of Health and the regional health bureaus and other agencies, just working together and contributing their part using their expertise. And also that is the major issues that can be raised, even though things still need more improvements. Again, the research, which is especially the national data regarding mental health, data capturing, which was even yesterday also raised. For your surprise, only depression, I think, if not mistaken, depression and the psychotic disorders only reach as a data aggregate for the policymakers. But as mentioned earlier, psychiatric disorder or mental disorders are more than 300. So this only two illnesses doesn't influence policy, and that makes not to get attention and need to be further worked on. So the role of professional association, as raised by Mr. Dagaye, yeah, we do have much professional associations, but there is limited capacity, as well as especially in bridging the gap using the research and the different further approaches to fill the gap of practice. For example, in our context, even there are a policy being designed, I hope, which give larger responsibility for professional association to, for example, to the level of licensing the professionals, as well as to try their best in keeping the standards of the service at the national level. So that is good thoughts if it is supported by the capacity building of the health professionals. To the innovation, when I summarize it, Dr. Lulu well addressed it, and even practically what's being tried at Emmanuel Mental Specialist Hospital, especially integrating medical care to the mental health care. So mental and medical health is really integrated and connected. We can't handle them differently. So bringing them together, caring for both, as I've earlier said, ICT professionals when fix their PC or like computer, software and hardware. So if you only fix the hardware and neglect the software one, doesn't work. And again, if you only fix the software and the hardware are still fragile, doesn't work. So both need to be fixed together. That's what can be taken as a good approach, as innovation to all level of our practice, starting from higher and tertiary hospitals to the level of primary health care, and also the innovation approach which helps us in neurosurgery, neurology as well as mental health are interlinked. And so the activities which now as innovation being done in Westerns and other countries, especially like brain stimulation and implementing of the stimulators and the neurosurgery, all this for mental health treatment can be well addressed if used very wisely. So this is all what we have for this session. I do really appreciate the panelists for sharing their in-depth insight, and also once again I would like to appreciate Oromiyaa Regional Health Bureau for coming in front by just planning this large event. Personally, I can't have words to express my gratitude to them. And also Ali Birra Foundation, our family, really appreciate the area they selected, and really something we need to work if we want to have full well-being of our society, and all of the researchers and all the guests and all the participants of these events. I do really appreciate what we have shared on this event, starting from yesterday. Thank you very much. Bye.
So I want to thank our moderator and the panelists for such very important addressing of this topic. So this is one of the two panel sessions we have for this conference. Yesterday we have entertained the first panel session, which is really tried to diagnose our healthcare system. Where is our healthcare in terms of availing and making sure of accessibility of the mental health care services. And today we have seen in this panel, which is very important really to the complementary to our yesterday's session, that is the research, training, and the policy perspective. So by this, I hope all of us, all the policymakers, the practitioners and the researchers are here are getting important take-home messages. So now we have some announcements. So the time for now is for tea break. So the tea break will be only for 15 minutes. So by that, we are also having some visits like we do earlier today. That is exhibit visit, and the poster presentation is also there. So you are invited to that. And next to this, the parallel session will follow our yesterday's arrangement, so you are invited to that. After that, based on our performance in these sessions, so we are going to arrange our following sessions. So now you are invited to the tea break. Nagantura.
ካምፓኒው መጀመሪያ ሲመሰረት በአፍተር ሴልስ ሰርቪስ የተመሰረተ ተቋም ነው። ዘን ኢንስታሌሽን፣ ፕሪቨንቲቭ፣ ኮሬክቲቭ፣ ካሊብሬሽን ስራዎችን በመስራት የሚታወቅ ተቋም ነበር። ዘን ያሉትን ጋፖች በማየት በ2016 ላይ ዋይድሊ ስራዎችን ኢምፖርት በማድረግ ስራ የጀመረ ተቋም ነው። እንግዲህ ቪዥናችን አሁን ባለን ስታተስ እና እየሰራን ባለን ሁኔታ አሞንግ ዘ ሊዲንግ መሆን ነው ኢትዮጵያ ውስጥና ኳሊቲ ያላቸው ፕሮዳክቶችን የማቅረብ የኤክስፐርቲስ ኤንድ ኮንሰልተንሲ ስራ የመስጠት ሆስፒታሎች ሲከፈቱ ምን አይነት ሴታፕ ሊኖራቸው ይገባል፣ ወርክ ፍሎው ምን መሆን አለበት የሚሉ የኮንሰልተንሲ ስራዎችንም እንሰጣለን። ሚሽናችን ያው ሃይ ኤንድ ፕሮዳክቶችን ኳሊቲ ያላቸውን እቃዎች የማቅረብ ነው። ቴክኒካሊ ኢምፓወርድ የሆኑ ባለሙያዎች እንዲኖረን ሀገር ውስጥም አት ፋክተሪ ሌቨልም ስልጠናዎችን ወስደው ሀገሪቷ ውስጥ ያሉ የሕክምና መሳሪያዎችን የመጠገን ኢንስቶል የማድረግና ከዚህ በፊት ከውጭ የሚገቡ ባለሙያዎች በእኛ ሀገር ባለሙያዎች የኢንስታሌሽኑም የሜንቴናንሱም ስራዎች እንዲሰራ የማድረግ ሚሽን ይዞን ያለው። እንግዲህ ኮሚኒቲው ደግሞ የተሻለ የሕክምና አገልግሎት እንዲያገኝ የተሻሉ የሕክምና ግብአቶች ማሽኖች እንዲገቡ የማድረግ ነው ሚሽናችን። እንግዲህ ግሮዙን ካየን ከአፍተር ሴልስ ጀምሮ ዘን ወደ ኢምፖርት ዲስትሪቢዩሽን ሲፒዲ ሴንተር እንደ ሀገር የመጀመሪያው በባዮሜዲካል የከፈተ ተቋም ነው። የሪፋብሪሽመንት ስራዎችን ወደ ማኑፋክቸሪንጉም እየሄድን ያለ ተቋም ነው። ዘን በትልቁ ደግሞ እንደ ሀገርም እንደ አፍሪካም የአፍተር ሴልስ ሰርቪስ ሌሎችም ስራዎችንም ከኢትዮጵያም አልፎ እየሰራ ያለ ተቋም ነው። በኋላ አሳያቸዋለሁ። እንግዲህ ምን አይነት ዋይድ ሬንጅ ናቸው እኛ ጋር ያሉ ፕሮዳክቶች ብለን ካየን ሁሉንም አንድ ሆስፒታል ሊያሟላ የሚገባቸውን ሁሉንም እቃዎች ኦር ማሽኖች ፈርኒቸሮችንም በማቅረብ የሚታወቅ ተቋም ነው። እንደ ሀገር የአይቪዲ የኢሜጂንግ የፒኤምኤልኤስ እቃዎችን በማቅረብ የሚታወቅ ተቋም ነው። ከአይቪዲ ምናልባት ከሎው ኤንድ እስከ ሃይ ኤንድ ያሉ ኦሮሚያ ውስጥም ብዙ ቦታ የገቡ ትላልቅ ማሽነሪዎችን ያስገባን ተቋም ነን። እንዲሁም ኢሜጂንግ የኤምአርአይ፣ ሲቲ ስካን፣ ኤክስሬ፣ አልትራሳውንድ ሌሎችም የኢሜጂንግ ማሽኖችን በማቅረብ እንታወቃለን። የፒኤምኤልኤስ እንግዲህ አሁን ዓለም ላይ የደረስንበትን የቴክኖሎጂ ደረጃ ሀገራችን ውስጥ በማቅረብ ግላንዶ ባዮሜዲካል ይታወቃል። ሶ እነዚህ ግሎባል ፓርትነሮቻችን ናቸው። እንደ ዓለም የሚታወቁ ብራንዶች በተለይ ከማይንድሬ ጋር በትልቁ እንሰራለን። ማይንድሬ እንግዲህ ዓለም ላይ አሁን አሞንግ ዘ ሊዲንግ ማኑፋክቸረር ነው። እንደ ዓለም በየፕሮዳክት ላይኑ ትላልቅ ቴክኖሎጂዎችን እያቀረበ ያለ ተቋም ነው። ሌሎቹም በየፕሮዳክት ላይ ናቸው። ከነዚህ ፓርትነሮች ጋር ግሎባሊ እንሰራለን። እንግዲህ ሌላው ትልቁ ግላንዶ የሚታወቅበት ምናልባት እያንዳንዱ እዚህ ያላችሁ ሆስፒታል ቤት ገብቷል ብለን የምናስብበት አንደኛው የአፍተር ሴልስ ሰርቪሳችን ነው። የኢንስታሌሽን፣ የኮሬክቲቭ ሜንቴናንስ፣ የፕሪቨንቲቭ ሜንቴናንስ እና ሌሎችም ከሴልስ በኋላ ያሉ ሰርቪሶችን በማቅረብ በጣም እንታወቃለን። ለዚህም ደግሞ እንደ ሀገር ትልቁን የሰው ኃይል ባዮሜዲካል፣ መካኒካል፣ ኤሌክትሪካል እና ሌሎችም ሙያ የሚፈልጋቸውን ባለሙያዎች በመያዝ እንደ ሀገር ትልቁን የሰው ኃይል ይዞ እየሰራ ያለ ተቋም ነው። እንግዲህ እነዚህ ምናልባት በሲቲ ስካን ደረጃ የሜንቴናንስ ከኢንስታሌሽኑ ጀምሮ አፍተር ሴልስ ያሉ የሜንቴናንስ ስራዎችን የካሊብሬሽን ስራዎችን እንሰራለን። ስኬጁል የሆኑ የፕሪቨንቲቭ ሜንቴናንሶችን በርቀትም ባለሙያዎቻችን ሰፖርት የሚያደርጓቸውን ስራዎች ይሰራሉ። እንዲሁም ደግሞ ስፔር ፓርቶችን በማቅረብ በተለይ ከኦሪጂናል ስፔር ፓርቶችን ከማኑፋክቸረር ጋር በመገናኘት በተለይ ከሚንድሬ ጋር ኤክስክሉሲቭሊ የምንሰራባቸው የስፔር ፓርት እቃዎች አሉ። ስለዚህ እነዚህ ነገሮች በትልቁ የምንሰራበት ነው። እነዚህ የተደረደሩት ከተሰጠኝ ሰዓት አንጻር አፍተር ሴልስ ሰርቪስ የምንሰጣቸው ባለሙያዎቻችን ዴዲኬትድ ሆነው ስራ የሚሰሩበት ተቋም ነው ማለት ነው። ዘን ምናልባት እንደ ኤክስፒሪየንስም እንደ መጀመሪያም ከሀገር ውጪ በመውጣት ኢኳቶሪያል ጊኒ ላይ የኦክሲጂን ፕላንት በእኛ ባለሙያዎች የተሰጠ ጥሩም ፐርፎርም ያደረግንበትና ለሀገሪቱ የውጭ ምንዛሪ በማስገባት በሌሎችም የሰርቪስ ትላልቅ ፕሮጀክቶች ላይ ከዚህ በፊት ከውጭ የሚገቡ የባለሙያዎችን በማስቀረት በእኛ ድርጅት የሚሰሩ በሀገርም እንዲሁም ከኢትዮጵያ ውጭም አፍሪካ ላይ ሌሎች ሀገራትም ላይ የሰርቪስ አገልግሎት እየሰጠ ያለ ተቋም ነው። አት ፋክተሪ ሌቨልም ትሬኒንግ እንደ ዴቨሎፕመንት ስኪላቸውን እውቀታቸውን እንዲያዳብሩ ባለሙያዎቻችን ቻይና ድረስ በመሄድ የሚሰለጥኑበት እድሎች ይኖራሉ። ዘንድ ሰርቲፋይድ የሆኑ ባለሙያዎችም ስላሉን እንደ ድርጅት ለምናመጣቸው እቃዎች ጥሩ ኮንፊደንስ እና ዋራንቲ በመስጠት እያገለገለ ያለ ተቋም ነው። ሲፒዲ ሴንተሮቻችን ባለሙያዎች በየጊዜው ስልጠና እንዲወስዱ ሰርቲፋይድ እንዲሆኑና በየጊዜው ከማሽኖች ጋር ሳይራራቁ ፋሚሊየር ሆነው እንዲቆዩ በሲፒዲ ሴንተራችን ለባለሙያዎች ስልጠና እንሰጣለን። እንግዲህ በቮለንተሪ ሰርቪስ ላይ ሲኤስአር ላይ በሰፊው እንሰራለን። በተለይ በሚኒስትሪ ደረጃ ሪኮግናይዝ የተደረግንበትና የፍሪ ሰርቪስ ክረምት ላይ ምናልባት ብዙዎቻችሁን እጃችሁን አውጡ ብል ብዙዎቻችሁ ታወጣላችሁ ብዬ አስባለሁ። ብዙ ሆስፒታሎች ክረምት ላይ በመድረስ የነፃ የኢንስታሌሽን፣ የሰርቪስ፣ የሜንቴናንስ ሌሎችም ሆስፒታሉ የሚፈልጋቸውን አዳዲስ ማሽኖች ስቶር ውስጥ ያሉ ኢንስቶል በማድረግ የፍሪ ሰርቪስ እንደ ሀገር እንሰጣለን። ለዚህም ደግሞ ጤና ሚኒስቴር በዚህ አመት ምናልባት የፕላቲኒየም የሪኮግኒሽን ሰጥቶናል እና እንደ ሀገር ተጽዕኖ እየፈጠረ ያለ ተቋም እንደ ሀገርም ደግሞ የሀገሪቷ የምትፈልገውን በዚህ ዘርፍ የምትፈልጋቸውን ሰርቪሶች በመስጠት ሪኮግናይዝ የተደረገ ድርጅት ነው። ምናልባት መሀል ላይ ያሉት ኢንጂነር ኢዲዲያ የድርጅቱ ባለቤት እንዲሁም እንደ ሀገር የመጀመሪያዎቹ ባዮሜዲካል ውስጥ የመጀመሪያውም ነው። ስለዚህ ዘርፉ ላይም በሰፊው እየሰራ ያለ ድርጅትም የድርጅቱ ባለቤትም በዚህ ልክ ስራዎችን እየሰራ ይገኛል። ዘን እነዚህ የቮለንተሪ ሰርቪስ ክረምት ላይ ስንሰራ የነበሩ ናቸው። ባለሙያዎቻችን በየሆስፒታሉ ሄደው ስራዎችን እየሰሩ ይገኛሉ። እንግዲህ ይህንን ሁሉ ስንል ግብይት አለ እናንተና እኛ ማዕከልና እንዴት ነው ያለው ግብይት የሚለውን ትንሽ ነገር ልበል። ዘን ካሽ ሴልስ ሞዳሊቲ ያለን የእጅ በእጅ ሽያጭ ለምናቀርባቸው እቃዎች። ሁለተኛው የክሬዲት ሴልስ ነው። በተለይ አሁን መንግስት ቤትም የግል ድርጅቶችም ጋር በሰፊው በክሬዲት ምንሰራበት አለ። ሶስተኛው አዲስ አፕሮችም ነው የፕሌስመንት ሞዳሊቲ ማሽኖችን በማስገባት ማሽኑ የካምፓኒ ይሆንና እነዚህ የኮንሱመብል ሬጀንቶችን ሰፕላዮችን በማቅረብ ድርጅቱና የሄልዝ ፋሲሊቲው አብረው እንደ ፒፒፒ የምንለው አይነት ሞዳሊቲ የሚከተል የፕሌስመንት አፕሮችን እንከተላለን። ስለዚህ በእነዚህ ሶስቱ አፕሮች ካረጋችሁን እንደ ድርጅት ሌሎችም ሰፖርቶች ካስፈለጉ በሰፊው አብረን መስራት እንችላለን ብዬ አስባለሁ። እንግዲህ ትላልቅ ተቋማት እንደ ሀገር ያለን ተቋማት ፖቴንሻል ከስተመሮቻችንም ናቸው። በፌደራል ደረጃ ያሉ ዩኒቨርሲቲዎች እነ ጅማ ዩኒቨርሲቲ፣ ብላክ ላይን፣ ሀረማያ፣ የካቲት 12 ሌሎችም ሪጂናል ኦሮሚያ ላይ በተለይ በሰፊው እንሰራለን። ኦሮሚያ ውስጥ የገቡ አዳዲስ ትላልቅ ማሽኖች በጊላንዶ የገቡ ማሽኖች ናቸው። ስለዚህ እነዚህ ተቋማት ከኛ ጋር የሚሰሩ ናቸው። ኢትዮጵያ ውስጥ ያሉ የፕራይቬት ሴክተሮች ከኛ ጋር ይሰራሉ። ኤንጂኦዎች፣ ዲያግኖስቲክ ሴንተሮች ከኛ ጋር በሰፊው እንሰራለን። ምናልባት ጊላንዶ የት ናት ምንድነው ለሚለው ጥያቄ ብዙ ጊዜ ለሰዎች ጥያቄ ስለሚሆን ጊላንዶች ሰፈር ነች። አንድ ኢሉባቦር ውስጥ የሚገኝ ኦር አሁን ቡኖ በደሌ ውስጥ ገቺ አካባቢ የሚገኝ አንድ የገጠር ቦታ ነው። የኢንጂነር ዲዲያ የቤተሰቡ የአባቱ መንደር ነች። ስለዚህ ጊላንዶ ነው የሚባለው። ሎካል ስም ስለሆነ ያው ደስ ይለናል። የውጪ ስም አይደለም። ስለዚህ ሎካል የመንደር አመጣጣችንን የሚያስተዋውሰን ቦታ ስለሆነ እንኮራበታለን በስሙ። ቴንኪው ማይንድሬ። ትንሽ ስለ ፕሮዳክቱ አንድ 5-6 ደቂቃ አንስተዋለሁ ለኪሩቤል 10 ደቂቃ ልስተውሽ። ታንኪው ጨርሻለሁ። ገለቶማ አማሪፋን ፊት የሚት ዲፈማ አፎቱ ናጎ እሺ አካም ጅርቱ እንዴት አደራችሁ? Good morning. This is Kirubel from Mindre. I'm working for IVD product line as a product specialist. So today I'm going to give you a brief highlight about Mindre and its solutions that can be applicable for different health facilities. That includes tertiary care hospital laboratories, general hospital laboratories, primary health care hospital labs, independent diagnostic labs. On top of that, we have also different solutions for imaging that includes ultrasound and X-ray, and also we have patient monitors and other life support solutions as a company. Of course, my focus today mainly will be on laboratory solutions. So as you can see, our motto is basically related to access to healthcare. So Mindre has believed that nobody, regardless of the economic situation or access to technology, equity is one of the key issues that we need to consider. That's why Mindre ensures everybody in the world, wherever the country, regardless of the economic level, the economic status, we need to just have access to medical technologies that help us to diagnose disease and also provide timely treatment and management of patients. That's why better healthcare for all is our motto. Sorry, any ላይ ሲደርስ ቴክኒካል ነገር ብዙ በዛ ችግር I think battery ሊሆን ይችላል maybe. Okay, it works now. Thank you. So Mindre has been in the last 30 years. We have been working across the globe, more than 190 countries. So as you can see, this 30 years journey basically provides a lot of learning for the company. Mindre is one of the rapidly growing companies in the medical device manufacturing industry. So as you can see, since 1991 until now, we're able to just achieve one of the top 20 medical device manufacturing company in the world. So our reach is, as you can see in the globe, we just serve more than 190 countries. It means that this is a global company. It's not like a Chinese only or European only, just it's a global company. As you can see, we have more than 80,000 employees. From these employees, almost we can say 1/3 of these employees are research and development staff. So Mindre's huge investment is on research and development. For example, before last year, on the published financial data or report, we can see that Mindre has invested $500 million for research and development. That's why, because of this, every year you can see 7 to 12 different product models, different features, and innovative applications can be produced every year because of this R&D center. These research and development centers can be found in different countries. Around 7 research and development facilities in China, 3 in United States of America, and also in Europe we have 2 manufacturing R&D centers. So R&D centers is not only from the Chinese plant. So this is a key aspect. The other thing is, whenever we talk about Chinese brand products, people feel that, oh, this is a Chinese product. They may feel that in the previous years, Chinese product has a low quality. That was the thinking. But now, the era has been changed. There is no like Chinese, US. So under the globalized world, we have been talking technology has no border. We just supply everywhere. As you can see there, for example, in Europe, more than 600 teaching hospitals, tertiary care hospitals, they're using Mindre products. If you go in US, for example, in those top 20 US hospitals, they use Mindre products. That includes, for example, like Johns Hopkins University hospitals, Mayo Clinics, and NHS. These are basically the top users of Mindre products. Of course, Mindre major business share, market share is 25% is in US. It's a big share we have in US. And the remaining in Africa and Asia, and 50% in China. So as you can see here, Mindre provides holistic solutions. We're not like, for example, if you have a plan to invest or open a hospital facility, we can supply you at least 60 to 70% of your demand. We can satisfy at this stage. So that's why we are providing. We're saying that we provide a range of solutions. Currently, the 3 product lines we have are, the mature product lines are patient monitoring life support solutions, and the second one is laboratory solution, and the third one is imaging. So from patient monitoring life support solution, those specific solutions that can be applied in emergency care, ICU, and if you go for OR and related service areas, you can find all important solutions, as you can see. From the imaging side, we're very good in terms of like providing ultrasound and X-ray across, the country. That includes public, private, as well as NGO facilities. When it comes to IVD or laboratory products, which is the main focus for my presentation today, it's easy to say that what we don't supply, instead of just saying that how many of products we supply. So we don't have right now anatomic pathology solutions and also basically molecular solution. The rest we supply. That includes clinical chemistry, hematology, immunoassay, microbiology solutions, urine analyzers, a range of products, automations from low-end up to high-end solutions we supply these days. So when we talk about laboratory, the key thing is that we would like to just answer in terms of value is, one of the things is reliability. The main concern from lab side is whether that result is reliable or not. So reliability is a major concern. Whether we are just providing or testing, providing a given laboratory test result. If you repeat a given result 2 times or 3 times, the consistency or the repeatability matters usually. One of the key aspects in terms of like reliability, the repeatability. The other aspect is the precision or the low imprecision, and the other aspect is the accuracy. So these things are the main aspect. The other one is workflow is a critical aspect. Whenever you have a laboratory, you need to have efficient workflow to just control your cost, maximize your quality, and provide a value-based service for your clients. And if you see in terms of operation, most of our devices, they are designed in a way that supports operational flexibility. So that's the other aspect. As you can see here, we provide a range of solutions that includes independent as well as integrated solutions. When we say independent, you can have, for example, hematology analyzer, CBC1 machine, or it can be integrated with other aspects. For example, morphology, slide making, hemoglobin A1C. It can be combined with hematology analyzers, and we can supply you that way. For example, chemistry can be tested separately, or it can be just integrated with immunoassay systems. So as you can see outside in the exhibition, in the side exhibition, you can see the integrated clinical chemistry and immunoassay systems. That maximizes the efficiency and minimizes the cost for end users. So that's why, as you can see, different instruments or analyzers based on the need and the interest of our laboratories. The other aspect is, as you can see, we can supply from entry level up to high-end laboratories. If your interest is for entry level, very low sample per day, we can supply that. If your interest is mid or high-end, at the same time, we can provide you those machines. We have also, as you can see on top of that, it says TLA. TLA means total laboratory automation. That means, for example, if you assume that this is an empty space, you want a lab, we can bring everything, an integrated system that includes hematology, chemistry, immunoassay, urine, everything. We can just install it. That will be changed to a laboratory. We call it total lab automation, end-to-end automated system. You just simply give your sample, it runs everything without the interference of any laboratorian or technologist. 1 person or 2 person can manage that. So that's the key aspect. Today, I think I would like to just focus on this for a few minutes, basically, on this integrated system. The one that you see outside is the left side, that is M680 system. So these are integrated clinical chemistry and immunoassay systems. Most of the laboratories these days, if you see the workload of laboratories per day, if you go inside, I can say 60 or 70% of their test volume relies on chemistry, immunoassay, electrolyte testing. So having this compact design instrument that has a very good throughput, for example, the one that in the left side, or you can find outside, you can do just 1,000 tests per hour. That includes for chemistry, immunoassay, electrolyte. Per hour, 1,000 tests.
one tube sample. You don't need to just draw different samples from a given patient. Only one tube sample. You give that serum sample, it runs and does all the tests. For chemistry, more than 70 types of tests. For immunoassay, we do more than 105 test types from different perspectives. So it does all this testing. So this technology is basically very, very beautiful technology that's integrated. I mean, the current technologies that the industry reaches, you can see all aspects on the systems. For example, you can see it has a very good interface that the laboratorian or the professional can interact easily with the system. It doesn't require very complex competency from the laboratory personnel because most of the things are being performed by the system. So it has a very good system. For example, this is the chemistry part, as you can see here, the clinical chemistry system. Very powerful system it has. What functions, for example, just to give you a highlight, it can accommodate 120 samples, load up capacity by rack system. So it can start as quick as possible in 1 minute. When you give the sample, it will start automatically. So when you have batch samples, like for programs like HIV and other programs, you may need like batch samples to be tested at a time. It supports as well. As you can see, one of the key aspects is for diabetic patients, from our public health data in Ethiopia, from the top NCD diseases, basically, one of the key aspects is diabetic, right? Diabetic mellitus. So in that case, HbA1c these days is a routine test. In our case, by using whole blood, you can test HbA1c without any pretreatment or separate analysis. It has a very good performance in that case. That's one of the key things that we can mention. Most of the time, you might be challenged in terms of like testing A1C when you have patients like anemic patient with low hemoglobin concentration. In that case, the hemoglobin A1C result is not accurate in most of the machines, as you can see. But in our case, we have just optimized, we just introduced an algorithm that optimally take the minimum concentration of the hemoglobin, then analyze the A1C test. That is one of the optimized function. And the other thing is, this is already part of it. The other key aspect that we can tell you from chemistry is how, for example, if you have a sample, usually in chemistry, it just uses absorbance method, basically. It just scans, and how much concentration, when the light passes through the tube, it will measure indirectly the concentration of the analyte that you would like to measure. In the olden times, we have had different techniques, filtered method, gray method. Now, we reached on PDR technology, panoramic dynamic recognition system. What does it mean, basically, for the patient perspective? One of the things is, it just reads almost all the wavelengths, around 16 wavelengths it can just scan. That means it doesn't mean slight concentration of the analyte. So accurately it just determines the actual concentration of the mash. The other key aspect is most of the time when you just measure a sample, one of the things is there are different interferences. That's not the actual analyte. You're interested to measure glucose. But the issue is there are different interferences that affect the glucose. So this system basically it identifies the interference from the actual analytes. That's another advantage you can get from the PDR technology. The other aspect is the electrolyte system. As you can see, very efficient electrolyte system we have. Very efficient, cost-controlled system we have. The lifetime for our reagents is very long for the laboratory, so that's one of the key aspects. As I mentioned earlier, different reaction systems can be affected because of the abnormal reaction from the sample or from the system. That's why our system, our technology basically minimizes those abnormal reactions and maximizes accurate reading of the testing. This is one of the key aspects that you can benefit from our machine. Most of the things is already supported by barcode system, so it can simply minimizes all the manual activities. So this is basically the interface, as you can see. So this is a sigma matrix. Sigma level is one of the key aspects. From you guys might be a researcher, I think. So as a researcher, one of the key issues you might be worried is whenever you measure something, the probability of error or undesirable outcome from a certain number of observations is a critical aspect. So in our case, this is a sigma matrix performance. It has been evaluated by the third party. It gives us a very good performance. We tested 30 routine biochemistry parameters. We just have achieved more than 5 sigma level, almost 95% of the tests. That's a key aspect for labs. What helps for the labs? One of the key things is the cost-related aspect. For example, every laboratory, they buy quality control material. The cost for quality control material is expensive, basically. So when you have stable system, your QC running frequency might be minimized. That maximizes, in terms of efficiency. You don't need to just run QC material every day. That's one of the advantage. And also you can have a quality report. So this is a key aspect that we can tell you. This basically is a performance-related issues. I know for the sake of time, I can jump from this. These are basically performance-related aspects. This is from the efficiency perspective. We can tell you several things. And in terms of test menu, currently we can have a range of test menu that helps for your patients. So we supplied for chemistry more than 70 types of tests for clinical diagnosis, patient monitoring, treatment follow-up, and others. Finally, I will take you simply about the immunoassay system. This is a CL2600I system that does hormone analysis, cardiac tests, for example, like high-sensitive cardiac troponin, NT-proBNP, and if you go for reproductive panel, we have range of tests. You go for tumor markers. For example, this machine does the highest number of tumor markers from the current industry benchmark machines. So we have more than 105 tests. So this is a very compact design, very productive system. It does 240 tests per hour in terms of performance. The key design from this machine is basically from the learning that we have been taking from the laboratories every time we've observed. So our R&D system just see what are the key things that usually affects the patient result. So we just identify the process and we just carefully analyze the risks that can happen in each process. On those risks, the innovation comes out. That's why, as you can see, process-based innovation comes in. Ultimately, it just provides very accurate test performance. So for the sake of time, I can just jump. As I mentioned, from chemistry PDR technology, for immunoassay, we have our own innovation, FS sampling technology, that minimizes the interference from any variants or interferences and just eliminates the risk of any interference that includes bubbles and as other factors. So this is FS sampling technology. It has its own algorithm. So the key aspect usually on immunoassay tests is the washing technology. As you can see here, less than 0.1 parts per million means a very controlled low carryover effect, our system. So that's a very important point. The other aspect is the maintenance, the temperature. Temperature affects the patient result in terms of analysis. That's why it has a very controlled temperature fluctuation system. The other thing in terms of quality control, as you can see, the long-term quality control performance is within the total allowable error, acceptable performance. As you can see, for end users, the lifetime, it has free of manual maintenance. There is no daily maintenance requirement. That's one of the cost aspects. And as you can see, the syringe, you can replace in 10 years. So that's the key aspect that you can consider. So most of the hidden costs or indirect costs are considered in our designs and help us our laboratories these days. As you can see, the shelf life for the reagent is very long once they are just opened also. The onboard stability is very, very interesting. So that's a key thing. So from PMLS perspective, we have a lot of solutions these days for critical care service or ICU as well and emergency care. So that's one of the things. As I mentioned earlier, for imaging, you can build your confidence having our system. So the key thing, Mindray, how it's just reached in this very short time to be on top of those top 20 basically medical device manufacturing companies. Mindray acquired very huge R&D centers and manufacturers globally. That's why one of the acquisition aspects help us for the jump, performance in the last couple of years. So as you can see, the manufacturing line is the largest in the Asian manufacturing plants currently. So we applied the robotic systems, and the AI is very routine in our manufacturing lines, as you can see. So that's all about. Finally, this communities, you guys are researchers and academicians, so this is the last message. What we want to tell you is Mindray is not like a company that simply sells a product and just go away. That's not the way that we're doing. We're aggressively working on knowledge management, evidence generation, and research programs. We have a lot of cooperations with universities, academics, and research institutes. So that's the major thing that we're doing currently. Whenever we have a new product, we want to do evaluation with different academic institutes and research institutes. And also we have different knowledge exchange platforms that can be organized locally, regionally, and internationally. That creates different minds together and just bring new ideas from different perspectives. So that's why we have a range of platforms that we would like to invite you in the future. Even this year, we have different platforms locally and internationally. So you're cordially invited in such platforms. So we have been doing a lot of work with international and governmental organizations. So ultimately, we want to make sure that better healthcare for all, regardless of the people's status, medical technology should be accessible. So we want to advance that every time. So we need to just focus on customer requirements always, and we will just enrich every time our end users, and we're very practical as much as possible, not 100%. We'll try to be very practical. We'll try to just keep our words, despite the fact that that affects the supply chain, as you know, in our country. So whenever there is a challenge, we want to just forge ahead. There might be a challenge, internally or externally, but we would like to see opportunities. As you remember, in COVID era, most of the industry has been affected. Mindre was the top performing season was during COVID-19. Because of what? We were looking always opportunities during difficult times. That's basically looking forward. That's the intention that we are here. Thank you very much. Appreciate it, Galatoma.
Thank you very much for Glando and Mendre for presenting very nice and exciting biomedical innovations. Just we are advancing more, so just I'm kindly invite Mr. Ephraim Mankuli from Adama Hospital Medical College to moderate this session. So kindly invite him.
Good morning. Welcome to one of the exciting this international health and mental health equity international research conference. So I am Ephraim from Adama Hospital Medical College. I am delighted to be the moderator of this session. So during these sessions, we have two panelists who are going to be present their research finding consequently. So then at the end, we will have a panel discussion. So having said that, I will introduce the first presenter, Professor Zode Qo'annoo from Jimma University. He is a professor of health, behavior, and society. And he has been published more than 114 research articles on a reputable journal. So he have also served on multiple positions at Jimma University. He have served as a member of ESIC working group and a member of Ethiopian Health National Innovation think tank, steering committee member at Jimma University, and he have also served as a member of COVID advisory councils at Oromiyaa Regional Health Bureau, chief of academic and research directors in Jimma University. And he have done a lot. And I have also awarded multiple honor. And to mention some of them, he have obtained an award on outstanding researcher from Jimma University, an outstanding lecturer from Jimma University, and a senior social behavioral change researchers on February 27, 2024. So we have done a lot. These are some of the list I've got from his profile. So he is going to be present as research articles on workplace stress, support, stress management, strategies for healthier lifestyle among health workers in Ethiopia. Please I would like to invite Professor Zode. Please welcome him to the stage.
Okay, thank you. This is Zaude. I'm from Jimma University and working entirely. I just started my education at Jimma, then started my career at Jimma. All my degrees from Jimma, and I'm made in Jimma. So, so thank you. So I'm going to make a very brief presentation on workplace stress, support, and stress management strategies among frontline health workers in Jimma. So there are so many team members. I'm on the behalf of them. So I will try to touch few things on introduction, objective methods, results, then conclusion, and finally recommendation. So workplace stress is first good to define what it is. And workplace related stress is refers to the emotional, the physical, and the cognitive strain and worries experienced by health workers, by individuals, due to, primarily job and job-related environments. So it occurs when work demands and the pressure exceed the employer's capability in terms of it could be knowledge, in terms of the capacity, in terms of the resource we need to perform the task, and generally the individuals are unable to cope up with the existing challenges. So here it can be related to the poor work organization, the environment we work. That means insufficient job design, the way the workflow is designed, management practice, unsatisfactory conditions, especially it could be from the incentive, it could be the environment itself, the control. Sometimes we may not have full control over what we do, and that's also one of the factors. Poor management support system, those are contributing factors. So importantly, globally there is an increasing trend of stress in general, and workplace stress is increasing over the life, especially following the COVID pandemic. These mental health problems in general is increasing, and the workplace stress is also increasing. And in healthcare, it reaches up to 60%. 60% of the healthcare workforce experience some level of stress. So the impact is very much clear. It negatively affects the health workers' physical and mental health, motivation, job satisfaction, and ultimately the performance. And this is definitely lowers the quality of the healthcare we are looking for. So why it is important for Ethiopia? Healthcare is very complex environment, and particularly due to like heavy workloads, sometimes long working hours, high patient loads, working in very remote areas where resources are very much limited, challenges are too many, ongoing pandemics, pressures, healthcare resources, including those technologies we have seen right now, is very much limited, and those are very practical implication to the mental health state of the worker. So understanding this factor is really important to provide evidence, generate an evidence that can inform design to intervention to promote coping strategies. So the objective is to determine the prevalence of what's the prevalence of this work stress, especially in those front lines. What are the available workplace support system for promoting healthy lifestyle? Then what are the coping strategies? How health workers are really coping with the challenges, the stress they experience. So this is basically the data is taken from a bigger project, a collaborative project, and it was done as a case study in Jimma area, involving like 5 hospitals, primary hospital, General Hospital was there, then referral hospital. And generally, 496 health workers were involved in this survey. Data was collected through self-administered but assisted by trained data collectors. Then we defined the stress level into low, moderate, and high based on the available validated scale. So here you see the workplace stress, the measurement issues. I will not talk detail of all these parameters. Workplace support system is there, social support is there, then finally the stress management strategies. So coming to the key result is that I directly go to the prevalence of this workplace stress. So based on our scale, you see 48% of, based on our measurement, 47% of the participants were no experience of stress. Then the remaining 53 has some level of stress. Okay, where low stress 25%, moderate 60%, and the severe form is 12%. Looking at by some key factors, males were more experienced of workplace stress as compared to females. Okay, if you see by facility type, those health workers who are working at referral hospital, they have more stress. In terms of qualifications, those are like first degree or bachelor degree, and salary gaining lower salary is more vulnerable to the stress. Okay, then what do people, health workers have social support system? Social support is very critical for mental health in general, but to cope up with stress, but this survey shows that approximately 86% of the health workers reported that their social support scheme or system is very poor in their work environments. That's the first box. Okay, and the moderate is 15%, and no health worker reported that they are getting a very good level of social support in their work environments. Okay, so high workplace stress among health workers is driven by a number of factors, institutional support including. So insufficient social support and inadequate stress management practice critically undermine well-being, job satisfaction, staff retention, and ultimately the productivity and the quality of care. If you look at this big graph, how the work environment is really healthy for the employees. So at the top, what we see is like those health workers who said their work environment is very supportive and healthy is mostly like nearly like 50%. Only half of the peoples were reporting, the health workers were reporting the work environment is healthy and supportive to live healthier life. So that means the remaining is there is a much more. Then coming to the stress management practice, there are no proven techniques to control and cope up with stress. And the question is, do people, health workers, are exercising at the time of when they feel, when they experience stress, what they really do. So look here, those techniques are like time management. Those who said we are not properly managing our time is 69–70%. Exercise is very low. Exercise, effective physical exercise is one of the techniques to cope up with stress, but only nearly half were exercising it. Sharing frustrations. Do you share your concerns, worries with others, with colleagues? Only 67% said they share their concerns, relaxations, affirming priorities. sometimes we are challenged with tasks which are not really priority to us. That means a skill to prioritize tasks, putting the first important tasks first and then sequencing it is really one way to cope up with stress, but practice is not optimal. Life balance, work-life balance. We need to think of how we are working and how we are exercising our social aspects as well, and that's also very low. Mentorship issues is also not optimal. It shows that critically areas like physical activities, techniques like relaxations, work-life balance, support system, there are more gaps on those areas. So these are explaining those things. So what is the key implication is that health workers, taking this the case from JIMA, healthcare facilities, health workers in Ethiopia face high workplace stress, like more than half. And stress is influenced by so many factors like workload, institutions, income disparities, or salary level, type of facilities. And then poor management in stress practices is also prevalent that exacerbates or aggravates the stress. So the recommendation is that regular stress management training, we need to empower health workers how to cope up with stress. Stress is basically it is a natural reaction and natural response to challenges. We cannot avoid it. So we cannot avoid it, and to some level it is also normal. So what is really important is we need to be, develop effective coping mechanisms. So tailored like psychosocial support system in health facilities are really important. Training, healthcare managers and leadership to provide an opportunity and a resource to overcome and cope up with stress is very important. Then integration of stress management into planning of healthcare facilities and health management is really really important. So based on this information, we need to translate these evidences into action, and what we are doing is along with our partners, we are conducting, we developed training module, training material, training well-developed training modules, and then we are providing training and understanding of those stress and how to cope up with it, at least in health workers around JIMA. This is a training we have undertaken. But the gap, what we learned during this activity is the gap is very high. It is very high than what we really imagine. And so really I call up to the regional health bureaus and Ministry of Health and the relevant stakeholders to consider these issues. The mental health of healthcare providers who care for healthcare providers care for others, but who care for their mental health. So it seems like neglected. So expanding this kind of training and opportunities is really important to build the resilience, the mental resilience of frontline health workers, so that they can care for others. So these are some of the references, and we are working with, this project is supported by Danida, Jima University, Kilimanjaro Medical College is partner, University of Copenhagen, and then Zanzibar State University. It's a collaborative project with involving 3 countries and 3 institutions. So thank you for your attention and for the opportunity, and Mr. Chairperson. Thank you.
Thank you, Professor Zaude, for your highly insightful and informative presentation. So I am looking myself as a worker in these presentations as a mirror. So similarly, I hope it works for all of us. So how many of our organizations are really supportive of alleviating this problem in the workplace, or supportive of this solving this problem? So we do have a discussion, So I hope you will have very important discussions on this topic. Next, I will call upon our next presenter, Mr. Emmanuel Adunya. He was trained on BSc midwifery at Bahar Dar University, and I have obtained his MSc in pediatrics and child health nursing from the same university, Bahar Dar University. And now he is an affiliate of Mizantep University. And he is a lecturer and a researcher. He have been published around 18 peer-reviewed journals. So he will present us on post-traumatic stress disorder among children and adolescents affected by armed conflict in East Africa, a systematic and a meta-analysis review. So this is our current problem also. So I will call upon Mr. Emmanuel.
Okay, thank you very much. Okay. My name is Emmanuel Adunya from Mizantep University. Okay, my presentation title is post-traumatic stress disorder among children and adolescents affected by the armed conflict in East Africa, a systematic review and meta-analysis. So this is my presentation outline. As introduction, the post-traumatic stress disorder is a trauma and stress-related disorder that develop following the exposure of actual or threatened days, severe injury or sexual violence, which is characterized by re-experiencing of the trauma and avoiding the trauma-related stimuli, negative change in mood and cognition, and change in arousal and reactivity. So as you all know, the armed conflict are the major public health issue in the globe and causing in profound physical and mental health crisis to civilians. So post-traumatic stress disorder is one of the most common and severe mental health challenges among children and adolescents in conflict affecting setting. So even though this post-traumatic stress disorder affects all age groups, the children and adolescents are highly vulnerable to this post-traumatic stress disorder because their brain and emotion are still growing. So the prevalence of post-traumatic stress disorder in East Africa ranging from the 22% up to 83%. And these studies were conducted in fragmented and in different regions. And the pooled prevalence in the associated factor of post-traumatic stress disorder has not been determined. So this systematic review and meta-analysis was conducted to bridge this knowledge gap and provide the comprehensive understanding of the post-traumatic stress disorder prevalence as well as the associated factors. So objectives, the general objective is to estimate the pooled prevalence of post-traumatic stress disorder and identify its associated factors among children and adolescents affected by armed conflict in East Africa. So we have two specific objectives. The first one is to determine the pooled prevalence of post-traumatic stress disorder among children and adolescents affected by the armed conflict. And the second specific objective is to determine the factors associated with post-traumatic stress disorder among children and adolescents affected by the armed conflict in this region. So the method part, first we systematically search the primary studies based on the different databases, including the PubMed, Henry, Web of Science, PsycInfo, Psychiatry Online, Science Direct, and Google Scholar from May 1 to June 1, 2025. So the all cross-sectional studies or case control studies that report the prevalence of post-traumatic stress disorder or and associated factors, as well as the study published in a full-length research and in English were included in our meta-analysis, whereas the conference paper, editorial report, and qualitative studies were excluded from our analysis. So the data were extracted using pre-customized Microsoft Excel, using the name of author, publication year, country, study design, and diagnostic tool, as well as the prevalence and predictors of post-traumatic stress disorder were extracted. Then the primary studies were assessed using the Joanna Briggs Institute critical checklist, and the extracted data were analyzed by using the R software, the version 4.3.2 for analysis, and the heterogeneity was assessed by using I-squared statistics, and the publication bias was evaluated by visual inspection of the funnel plot and the Eager test, and the result were presented in forest plot as well as the summarized table. So the result and discussion. First, we identified a total of 933 articles. Of these, 450 articles were excluded due to duplication. After reviewing the abstract and the title, additional 431 records were excluded due to irrelevance. And after reviewing the full text article of 52 studies, the 10 primary studies were meet our inclusion criteria and were included in our meta-analysis. So all studies were published, conducted and published between 2007 and 2025, and all studies were cross-sectional in design and conducted in 5 East African countries, 4 from Ethiopia, 3 from Uganda, and single studies from Kenya, Sudan, and South Sudan. So based on these 10 studies, the prevalence of post-traumatic stress disorder among children and adolescents affected by armed conflict was 47.6% using with 34.9 and 60.2 confidence interval. So our finding is in line with the study or the systematic review and meta-analysis conducted in Middle East, which reports the prevalence of post-traumatic stress disorder in Syria 36 and in Palestine 36. However, our finding is notably higher than the global estimate, which conducted the previous, which was 29.4%. So this difference could be justified by different factors. First, unlike the global review, our systematic review and meta-analysis was conducted specifically on East Africa, the region where the ongoing conflict, political instability, and humanitarian crisis have been deeply affected community. Second, our study include both the adolescent and the children, whereas the previous systematic review and meta-analysis include only adolescents. So the children often react trauma differently from the adolescent. Finally, in East Africa, the limited access to the mental health service and fragile system may worsen the mental health effect of the conflict. So the predictors of post-traumatic stress disorder, the children and adolescents who had been exposed to the war-related trauma were 2.5 times more likely develop post-traumatic stress disorder than those who had not. This finding was consistent with the evidence from Syria. So this could be explained by the experience like bombing, shooting, and forced displacement could overwhelm their coping ability and leaving them vulnerable for fear, grief, and insecurity. So the second factor we identified is the witnessing of the killing of family member or friends. So witnessing the killing of family member or friends were 2 times more likely develop post-traumatic stress disorder than who did not. This finding is consistent with the study conducted in Palestine. So this could be explained by the witnessing of the killing of loved one is deeply traumatic, and it creates intensive fear, grief, and loss of safety and trust, which may increase the risk of post-traumatic stress disorder after conflict. So the last factor is the being female. So females were 1.5 times more likely to develop post-traumatic stress disorder as compared to the males. So this finding is consistent with the study conducted in Palestine. So this can be explained by the biological factor. Girls often show higher stress reactivity and hormonal difference, which affect the coping ability after trauma. The other important reason is social and cultural factors. So in many conflict affecting setting, girls have less autonomy and fewer opportunity to seek help, and greater exposure to gender-based violence, including sexual assault, early marriage, and domestic abuse, which makes a compound trauma and increase the post-traumatic stress disorder. So as a conclusion, in East Africa, the prevalence of post-traumatic stress disorder among children and adolescents affected by armed conflict was found to be high compared with the global estimate. And the experiencing of war-related trauma, witnessing the killing of family member and friends, as well as being female, where they significantly increase the risk of post-traumatic stress disorder. So as a recommendation, this finding highlights the need of integrated and gender-based intervention, including the provide trauma-focused intervention in the community, school, as well as health facilities. Offer the mobile mental health and psychological support, training the community health workers in post-traumatic stress disorder to screen and basic care, as well as the referral system. So the other one is strengthen the family and the community resilience in the conflict affecting setting and integrate the child and adolescent mental health into humanitarian service and post-conflict policies. Okay, this is some of the reference. So finally, I would like to thank the Oromiyaa Health Bureau and Ali Birra Foundation, as well as the organizing committee, for inviting me to present my work. Thank you.
Thank you, Emmanuel, again for your very nice and informative presentation. As you all know, war is not desirable. So it is better to prevent, but once it happened, we need to think of its consequence. So one of the consequences is like this one. So having said that, this is a time for discussion, so I will invite the panelists to the podium and give the chance for the audience for reflection, questions, and any issues you want to add. Please, Professor Zaude, Emmanuel, please come to the podium. So the turn is yours. So you can show your hands. Okay, Professor
Thank you very much, the presenters, for your nice presentation. My question goes to the first presenter, Professor Zodi. Thank you very much for doing research on stress among health professionals. It is unavoidable, of course. The profession itself is stressful, and stress is unavoidable. The most important thing is the level of stress and how the health professionals cope with it. Otherwise, I think it's likely to be 100% to have stress among health professionals. I would have liked to see the differences in the level of stress among health professionals working at different departments, because some departments are more stressful than the others. For example, it is not the same for health professionals working at ICU, ART, psychiatry department, dentistry. These are considered to be the most stressful occupations. Therefore, it would have been nice if you tried to compare if there are differences in levels of stress among health professionals working at different departments. The other thing I was surprised with was life balance was 57%. I'm very surprised with it because for health professionals, it is very difficult to balance their work with leisure activities. This research is telling us that about 57% of health professionals balance their work with leisure activities, but I don't think they have enough time to balance their work with leisure activities, because they are supposed to work for very long hours. They may be on duties, they may have long surgeries, they may have emergency patients, very high flow, so they can't work according to the schedule. So how would you describe how this result came? Thank you. For the second, it is just a curiosity question. Were you the sole author of the systematic review and meta-analysis? Because I didn't see the list of authors. It was only your name that was displayed. If you are the only author of the systematic review and meta-analysis, how do you see its scientific rigor? At least you have to have 3 researchers to search for meta-analysis and systematic review, including the retrieving of articles. And if you have agreement and disagreement, a third person may be necessary to reconcile that disagreement. So I just want you to tell me whether you were the sole author or you have other co-authors. Thank you.
Thank you, Professor, for raising very relevant points. I will give you the chance.
Thank you very much. I'm Dr. Yasin from University of Gondar. And thank you for your nice presentation. Basically, I'm a psychologist, and I'm concerned about the presentation presented by Professor Zodi. My question first is, how did you measure social support? Because the study is conducted in Ethiopia, yeah, in Jimba, yeah? And you said like 85.5% of the participants do have poor social support. How dare this happens in a collectivist culture, yeah? And this contradicts with other findings. You know why? You are saying like 67.0% of the healthcare professionals were sharing their frustration, yeah, as a stress management method, yeah. And again, you also said like 61.1% of them do have mentors or advisors. And contradicts with the poor social support that they have. So they have either no one to share their frustration, thereby we can conclude like they do have poor social support, or they do have high social support. So the data contradicts with itself. All right. Yeah. Yeah, that's my question, and I need an explanation on this one.
Thank you, Doctor, for your question.
Okay, thank you both for your nice presentation. I do have one question for the second presenter. Of course, when we see the result of meta-analysis, you have applied the random model just to see the pooled evidence or effect size. So actually the I-square is about 99. That means it shows a substantial heterogeneity among the studies. So how could you interpret the finding? The second question goes to the first presenter, Professor Zaude. Of course, the level of stress might depend on the level of work engagement among healthcare forces. So did you see the work engagement level and the meaning of work they give to entirely to their profession, because it is very mandatory? In your implication, you narrated that strengthening workplace support system are important to reduce disparities across healthcare facilities, are essential. So I think this is about workplace support. It is not social support and other. So what kind of social support are you suggesting? And another question is about the stress management strategies we know before are actually there. So what's innovative, maybe new idea, which is tailored to Ethiopian context, you came up with effective stress management strategy? Thank you very much.
Thank you for your question.
Okay, thank you so much. I do have one comment and around 2 questions for the second presenter. Actually, my first question is, you have recommended some pointers for based on your finding. However, your results were from different countries. Do you think that this all recommendation works across all countries? And the second question is, you have tried to pull still results from South Sudan, Sudan, Ethiopia, Kenya, and so like. These countries do not have the same conflict and disparities. So which country contributes more for the maximal prevalence of the problems that you have presented? And I wonder if you come up with a subgroup analysis of your results. And how do you think comparing the result from single study with that of meta-analysis and systematic review? Because I have seen that you have compared your result from Palestine and Syria with that of what you brought now. As the same manner, you have compared your result with the results that come from the globe, and the results, yours, while yours is from the single region. So how do you think that? Thank you.
Thank you, Getu. I think it's better to give the floors for the panelists to react on the question. I will start from Professor.
Thank you. I really appreciate the comments, feedback, because this is still an ongoing program, and data is really, a piece of the bigger project. The project is not only mental, but it's also involving some other aspects. So the comments are, I will consider the comments, especially those around the analysis. For example, whether this level of stress is really vary by a specific work nature, or where or in which units the healthcare workers are working. The problem with this is that the sample is relatively small, and representation of some specific category of health worker is not really adequate enough for subgroup analysis. So, for example, I cannot tell you now, like, nurses who are working in, let's say, ICU or another department experience more or less level of stress. So what we see is by level of facility, definitely those who are working at high level healthcare, like hospital, especially the referral, they are more, the level of experience of stress is relatively higher. The other issue is in terms of the social support system. This data, self-report data, is always, it may not be the way we are expecting. The tools we are using might be have also some problem, but the issue is we just ask it or fill out to respond to what extent they feel they get the social support in their work environments. Okay, there are the standard scale, and with that level, almost even none of the response was fall in very good social support level. Okay, it's moderate and poor, and 85% is a kind of poor category when we define it. So this is within their work environments. But coming to in relation to this, there are specific types of recommended type of strategies and techniques to reduce stress, where individual can simply exercise even at the workplace, at home, and anywhere. And having this in mind, like I displayed the big graph, and that shows like nearly half of the population either somewhat agree or strongly agree that they can do those techniques. Okay, so that is still it's not like a very high finding. Like for example, if you take like work-life balance. The work-life balance, we didn't really calculate the time they invest on the work and the other social activities and other business, but how people perceived that their life is somewhat balanced when they compare with their work, their professional activities. Okay, so if individual still those things are need to be like explored, how people even define the balance. I mean, work-life balance. Okay. So for me, maybe like working, let's say for current status, working like 14 hours or 15 hours, maybe fine. I would say like okay, I'm balanced. Okay, for others may define it like okay, working life balance is when I dedicate 8 hours for my work and the remaining for social and other activities. So those perceptual and how people define and understand the work-life balance still it matters. In terms of what kind of effective strategies, this question is very good question, but we need to study it. What is really an effective strategy to reduce stress? We need to do a very good systematic review and synthesize best available evidence on what is really based on the context effective and the most acceptable strategies to reduce stress, and then pilot it in the local context and see how much it is really effective. And we are not doing that, like effectiveness study we are not doing, but this is a very good question for the future to consider and look at it to make, you know, because what we learned is health workforce is really experiencing, as Professor said, everyone is, if the level is different, it could be 100%, yes. If you consider every level of even acute level of stress, all of us, we pass through that phase and every moment, every time. But the stress that can lead to somewhat problems, burnout and other psychological issues. In fact, I'm no psychologist, I'm public health. But the team, we have psychologists, and he's not around. That's why I'm handling this part. Otherwise, a team of experts, psychologists and psychiatrists, also team of the members, member team. The recommendation, the social support system, it is what is most important thing is there must be a support mechanisms. In terms of the, when you say support, it can be in terms of resources. Where do people, health workers should know go when they, go for help or support when they feel, they experience stress. Do we have that mechanism in health facilities? Do we have that kind of platform? No. What we have learned from last week, we have no training health workers on this issue, and the story we are hearing from people is really, you know, itself is a number of problems. How people react to even the situations when things are beyond their control, you know, get them, you know, trapped in again in even another psychological trauma. One of the nurses said she's working in an emergency unit, and like 2 years ago, she, you know, there were car accident, and like 15 people, 15 people who were in the car, and all of them were died, including children. And she saw this, you know, with her naked eye, and she gets shocked, and you know, she's, you know, developed, you know, psychological problem, and she was on treatment because of this. So the issue is how people see it, even how we can react to a situation. Do we have that skill? Sometimes we train people to become, you know, empathy or sympathy. Okay. Do people really reflect that emotions? Okay. I suffer. You suffer and I suffer. If health workers don't feel like that, and them suffer taragal, them suffer karakuny, yes, that's problems. Okay. I'm not saying we should not, health workers should not share the emotions, but it should be more of cognitive, you know, cognitive understanding. If they share the entire emotion and they become a patient themselves, that is really a problem because the environment is very, very challenging. So those kind of skill, developing a skill and you know, training on effective in quotation, effective interventions and support system, our health worker can have developed somewhat a good capability and coping strategy to respond, to live with the stress environment, because we cannot avoid the stressor, and the environment is always, you know, full of stress. Maybe I'll check this question. If you have missed, I will come back.
Okay, thank you for your nice suggestion and comment. The first question is, where is the other authors? Because the systematic review and meta-analysis should be conducted more than one person. Our systematic review and meta-analysis, the author is 4, but for the sake of the PowerPoint preparation guideline, and presentation. We have not present here, but the author are 4, including me. The second question is, how could interpret the finding, because there is high heterogeneity between the primary studies. So even though our finding has high heterogeneity, we conduct subgroup analysis based on the country, diagnostic criteria, and publication year. So the reader can use either the pooled prevalence or the subgroup analysis by country. And the subgroup analysis was conducted based on the country. The studies who had more than 2 studies, so the prevalence of post-traumatic stress disorder in our country, Ethiopia, is around 39%, and in Uganda is 44%. But in the single studies conducted in South Sudan is 73%, and in Kenya is 43%. So we conducted the systematic review and meta-analysis based on the country diagnostic criteria as well as publication year. The other question is, how do you compare your finding from the single study conducted in Palestine and Syria? We compare our finding in the similar studies, which means systematic review and meta-analysis conducted in Syria as well as in Palestine, not the single studies. Okay, this is all about what I have. If you have any additional, you can.
Okay, thank you, the panelists, for their explanation. So I would like to thank also the participants for raising. Yes. Okay. Okay.
Thank you very much for the chance you have given me. I just want to read this one because it's an ethical issue. In your presentation, Professor Zaude, you have put the pictures of your participants. And sometimes it could be dangerous for our participants. ሚስቴ ብትኖር ሳውን እዛ ፎቶ ስታሳየኝ ሚስቴ ብትኖር ሚስቴ ጋር ይጀልጣል ነው ማለት so and as a researcher we are not supposed to risk our participants, yeah. So I suggest not using pictures in your presentation. Thank you very much.
Would you like to react?
ፓርቲሲፓንት አይደለም የፕሮግራም ነበረ ትሬኒንግ ፕሮግራም ነበረ ኢንፋክት እኛ ራሳችን ኦንላይን አይደለንም አሁን you are already online እና ኢቲካል እንትን እየጠየቁን አይደለም አይደል so when you are doing a program I know ethical procedure ምንም ጥያቄ የለም but when you are running a program just like this you are already live transmission even. Okay, you will not ask anybody, everyone to give a consent to be recorded. But research is definitely it has own ethical procedure, protocol, and that was reported as evidence translation, where based on the evidences, what we are really doing in Jimma. For sure, this also not publication, just only for the sake of presentation, and I mean, it's quite a different program, and research is, as we all know, is different. Thank you for the comment again.
Thank you, Professor. I think this is a misunderstanding. These are not the participants of the researchers. Rather, post-research, they have conducted the training. Yeah, so... Okay. Anyway, let's take the concern. Okay. Let's consider his concern, but the ethical explanations will be managed, has to be managed in your process. So having said that, we would like to thank participants for giving their insightful comments. So the panelists will consider the constructive comments and try to incorporate in your final outputs before incorporated in our ahead of program policies, okay? So let's applaud the presenters and let's thank them. Thank you very much. So this is a peak time, the lunch time now. ነገርን ካስረዘምን ጥሩ አይደለም። ይሄንን ብለን መልካም ምሳ መልካም የረፍት ጊዜ እንላለን። እናመሰግናለን።